within each session, each set of presenters, for you to ask questions and make your comments. So now we begin with, now that I've done the overview, we will begin our first session for the day with presentation from Senator Morris. Is it Senator Morris, right? Yeah. Creating an accessible healthcare system in the Caribbean. Oh, sorry. I haven't woken up yet, as yet it seems. Yes, our presentation, Creating an Accessible Healthcare System in the Caribbean by Dr. Floyd Morris. But I will introduce him, although I believe most of you know Senator Morris's story, right? And it's a long one. So I'm just going to give it to you very briefly. Information. Oh my gosh, I can't believe this. Okay, yes. How could I not find it? Dr. Floyd Morris, Creating an Accessible Healthcare System in the Caribbean. That's what he will speak on. Senator Morris is the director of the University of the West Indies Center for Disability Studies. He's a specialist in the political communication and disability studies. He has researched and published extensively on these areas, evidenced by over 25 international publications. This includes a single authored books and an edited, two single authored books and an edited peer-reviewed book. Senator Dr. Floyd Morris is one of the leading experts on the subject of disability, and in recognition of this, was elected to the UN Committee on the Rights of Persons with Disabilities in 2020 for a 4-year term. He was instrumental in the negotiations and finalization of this treaty, that's the UNCRPD, between 2002 and 2006. He was also instrumental in the design and passage of the Disabilities Act of Jamaica, approved in the Parliament in 2014 and came into effect on February 14, 2022. So that's just the introduction of the book about Dr. Morris. And now we hand over to him for his presentation.
Thank you very much, Miss Goff, who I can safely say is my colleague, friend, and ally. And she's whispering sometimes, you know, but I have her as my friend all the time, all the time. We might jive each other, but we are friends all the time. A pleasant good morning to the members of the committee and those who have joined us online via Zoom or YouTube for this very important conference. And my presentation today will focus on creating an accessible healthcare system in the Caribbean. And in so doing, I will be drawing extensively from a research that was conducted by the UWI Center for Disability Studies in 2021 on the issue of healthcare for persons with disabilities. And you will see, based on the methodology, what we have drawn, we did in that research, and some recommendations. But I want to indicate that accessibility comprises various components, various aspects of healthcare and life relating to persons with disabilities, and these are captured in the research project. So I start with a background. The UWI Center for Disability Studies in 2021 embarked on a special research study on the situation of healthcare for persons with disabilities in the Commonwealth Caribbean. The research came within the context of health being a fundamental right for persons with disabilities, as ensconced in the United Nations Convention on the Rights of Persons with Disabilities. Persons with disabilities in Jamaica, for example, have expressed their concerns about access to healthcare in a socio-economic study conducted in 2015. The study revealed, among other things, that persons with disabilities were experiencing long waiting hours in the public health system. The UWICDS believes that there is the need to solicit more data on the population of persons with disabilities where healthcare is concerned, since it is one of the major factors contributing to the marginalization of this group. Resultantly, the entity embarked on a focus group discussion of persons with disabilities from across 4 Commonwealth Caribbean countries, namely Jamaica, Trinidad and Tobago, Grenada, and Barbados. Cumulatively, these 4 Commonwealth Caribbean countries have approximately 70% of the population of persons with disabilities in the region. The research study was under the general sponsorship of the Commonwealth Secretariat based in London, England. The policy problem. Jamaica, Trinidad and Tobago, Grenada, and Barbados are independent Commonwealth Caribbean countries which gained political independence from Britain in the 1960s and 1970s, respectively. Upon gaining their independence, these countries inherited a number of social institutions as a part of their governance structure. The healthcare system is one of the social institutions inherited from their colonial past. But contextually, this healthcare system was constructed on the charity and medical models of disability. In these models of disability, focus has been on the curing of the disease affecting the individuals with impairment and limited attention to the contextual factors that was impacting on the participation of that individual with the impairment in society on a daily basis. Thus, the entire healthcare system within these 4 Commonwealth Caribbean countries poses considerable problem for persons with disabilities, as the existing healthcare legislative policy and programmatic framework conflicts with the human rights model of disability. The problems become manifest in a modern era where the human rights of persons with disabilities is being recognized globally. Since these 4 countries have signed and ratified the CRPD since its establishment by the United Nations in 2006, they are duty-bound to honor the provisions of this treaty. The findings from the research study highlighted these systemic challenges. The research study. The responses of the participants in the focus groups were captured thematically. There were 5 focus groups, inclusive of a special grouping for persons who are deaf and hard of hearing. All the participants were persons with disabilities and consisted of males and females from rural and urban areas. The following are the themes captured in the focus group discussions, and these are critical to the issue of accessibility of healthcare. Health-related programs and policies for persons with disabilities, special healthcare facilities for persons with disabilities, COVID-19 and healthcare for persons with disabilities, affordability of healthcare for persons with disabilities, accessibility of healthcare for persons with disabilities, the availability of health care to persons with disabilities, and the attitude of health professionals towards persons with disabilities. All of these factors affect the general accessibility of health care for persons with disabilities. The research findings. There's a heterogeneous grouping of disability across the Commonwealth Caribbean, and these were represented in all the focus groups. However, the challenges and experiences of persons with disabilities, as adumbrated in the focus groups discussions, are very homogeneous. The detailed report on the situation of healthcare and persons with disabilities in the Commonwealth Caribbean demonstrate this homogeneity. The findings and recommendations contained in this presentation, therefore, is representative of the views of persons with disabilities and in keeping with best practices. And I start with the first finding. Health-related programs and policies for persons with disabilities. There are not many health-related programs and policies that are designed for persons with disabilities in the Commonwealth Caribbean. As indicated earlier, the healthcare system in the region had been predicated on the medical model of disability. Therefore, no major programs and policies have been developed for persons with disabilities. In Trinidad and Tobago, for example, there are no specific programs or policies relating to persons with disabilities in the healthcare system. Persons with disabilities in Trinidad and Tobago are concerned about the lack of specific programs and policies relating to healthcare for persons with disabilities. In the focus group discussion, they pointed to a mention in the National Disability Policy for Persons with Disabilities. However, they are very concerned about not having any specific healthcare programs and policies for persons with disabilities. Special healthcare facilities for persons with disabilities in the Commonwealth Caribbean. In the Commonwealth Caribbean, there are extremely limited special healthcare facilities for persons with disabilities. In the context of Jamaica, there is the Bellevue Hospital and the Sir John Golding Rehabilitation Center. However, as intimated by participants from the focus group in Jamaica, these institutions are not able to cater to all the needs of persons with disabilities. COVID-19 and healthcare for persons with disabilities. In general, no special provisions were made for persons with disabilities at health facilities in the Commonwealth Caribbean where COVID-19 is concerned. Barbados is an exception in this regard, as there is an arrangement between the Ministry of Health and the Barbados National Council for the Disabled to get persons with disabilities in that island vaccinated. The lack of particular measures to cater to persons with disabilities during the COVID-19 pandemic is disturbing, as it serves to compromise the health condition of some of these individuals whose disability are caused by particular disease, sorry. The affordability of healthcare for persons with disabilities. Healthcare for persons with disabilities is generally very expensive. This is due to the compendium of services that are associated with the impairment of the individual. The costs for health insurance, medication, transportation, and assistive devices are not affordable to most persons with disabilities, even if they have a health card. Additionally, persons with disabilities who require items such as adult diapers cannot afford it. All of this must be taken into in the context of data showing high levels of unemployment among persons with disabilities in the Commonwealth Caribbean. Accessibility of healthcare for persons with disabilities. Healthcare is accessed both privately and publicly, but mainly publicly by persons with disabilities. The public option is utilized by most persons with disabilities because it is available free, notwithstanding the long waiting hours. Transportation is a barrier, especially in rural areas where there are no accessible motor vehicles for wheelchair users. Some taxis refuse to take these individuals, and when they do, they charge them extra. Most healthcare facilities in the Commonwealth Caribbean are not accessible to persons who are blind, low vision, and wheelchair users. This makes it difficult for persons with disabilities to navigate the health system by themselves. Information is not presented in an accessible format for persons with disabilities in the healthcare systems. Some persons have to resort to Google to access information. Some persons with disabilities even have a difficulty in completing documents at health facilities. As articulated by participants, access to medical assistive aids is a particular challenge for persons with disabilities throughout the Commonwealth Caribbean. These assistive devices are expensive, and most persons with disabilities are unable to afford them. The availability of healthcare to persons with disabilities. In the Commonwealth Caribbean, healthcare is available to persons with disabilities. However, the extent of the availability and the quality of the availability seems to be a challenge. When we speak of the availability of healthcare in the context of this research study, we are referring to the ease to which persons with disabilities can access healthcare. While healthcare is available for persons with disabilities throughout the Commonwealth Caribbean, there are a number of challenges affecting its availability to members of this marginalized community. Financial costs constitute the major challenges for persons with disabilities. Participants in Grenada spoke extensively to the situations. Stigma and stereotyping is another issue affecting the availability of healthcare to persons with disability in the Commonwealth Caribbean. Persons with disabilities are perceived in the negative light in the Commonwealth Caribbean, and readily availability of healthcare to these individuals. Participants in the focus group for deaf and hard of hearing individuals were quite explicit on this matter. All right, and I'm going to quickly over the issue of attitude as it relates to persons with disability, and go into the recommendation. Policy recommendation. In light of the findings from the focus group discussions held in the 4 Commonwealth Caribbean countries and the special discussion with deaf and hard of hearing individuals relating to accessible healthcare for persons with disabilities, the following are some policy recommendations that must be adopted to improve the provision of healthcare to this marginalized population. 1, there should be a radical shift from the medical model of disability to an acceptance and implementation of the human rights model of healthcare for persons with disabilities. In so doing, the right of persons with disabilities to healthcare must be given priority. 2, in making this transition from the medical model to the human rights model of disability, ministries of health in the Commonwealth Caribbean should modernize all their laws to ensure that it reflects the human rights approach to disability. 3, ministries of health should move to capture relevant data on persons with disabilities using their healthcare and health facilities so that a more systematic and strategic approach can be adopted towards treating persons with disabilities. 4, ministries of health should move towards the training of all health workers in how to relate and deal with persons with disabilities. This should include the medical professionals as well as ancillary staff. 5, the Faculty of Medical Sciences at UWI-Mona and all other medical training institutions in the Commonwealth Caribbean should ensure that all medical students are trained in how to relate with persons with disabilities. 6, there should be an immediate effort to make all health facilities across the Commonwealth Caribbean physically accessible to persons with disabilities. This should include the installation of proper bathroom facilities and proper signage at health facilities for persons with disabilities. Finally, conclusion. It is indisputable that persons with disabilities in the Commonwealth Caribbean have a right to access health care. But for this right to be fully recognized, there has to be a seismic shift in the legislative, policy, and programmatic landscape of these countries, starting with a radical shift from the medical model of disability. Government must ensure that there is a different approach to how persons with disabilities are treated in the healthcare system. The shift must be towards the human rights model that is entrenched in the CRPD that was signed and ratified by these Commonwealth Caribbean countries. A shift to this model of relating to persons with disabilities will end the dichotomy that exists in the healthcare system in treating persons with disabilities and stalling their access to quality health care. A dichotomy that is impeding the rights of persons with disabilities in the Commonwealth Caribbean and stalling their access to quality health care. I thank you. I thank you.
Thank you very much, Dr. Morris. I think you have just gotten a new designation of the greatest timekeeper on earth, because it is really not like Dr. Morris to end a presentation within the given time, and did it so well. I must say, he had 20 minutes and he did it in 19. Let's give him another hand. Yes, and his presentation, as you listened, gave you a background to the issue that he spoke about. He also gave you some statistics, and that's what we are short of in Jamaica and in the Caribbean, I should say, on disability. And he gave some statistics from several countries, which many of us listening can relate to, especially if you're a person with a disability or work with persons with disabilities. What I also liked are his policy recommendations. And I'm sure if they're taken on board by first policymakers, we'll have a much improved healthcare system. He used a word to describe the changes that need to be made: seismic. And most times when we hear that word, we think of earthquake, earth shattering. And I guess it speaks to the level of changes that need to be made in order for us to achieve the full inclusion of persons with disabilities and the quality healthcare that we need to have, right? So thank you, Dr. Morris. We now move to our next speaker in this session, Dr. Bether Parry, and he will speak on access. My apologies, Dr. Parry. She will speak on healthcare for persons with disabilities, the case, the Trinidad case, Okay. Now, Dr. Bether Parry is a postdoctoral fellow at the Sir Arthur Lewis Social and International Institute of Social and International Studies. I'll read that again. Dr. Bether Parry is a doctoral fellow at the Sir Arthur Lewis Institute of Social and Economic Studies at the St. Augustine campus of the University of the West Indies. She uses quantitative, qualitative, as well as mixed methods to pursue her research interest in disability studies. She has focused on education, poverty, and social care. Now we welcome Dr. Parry to present.
It's about this conference.
Make it international. Hello? Technical team, can you say what is happening? Bether Parry. Parry. She's online, but we're not hearing her. Is she muted? Can you unmute her?
Seeing her online, her presentation is on the screen.
Yes, but
Bether?
Are you hearing me?
Yes, we're hearing you now.
Great. Thank you, Chair, for the introduction. Good morning, all, and I want to say that I'm very thankful for the opportunity to present my work at this conference. And just a correction, the pronunciation of my first name is Bipaya. No worries, though. I know it's a little difficult in seeing how it's spelled in terms of converting that into pronunciation. So what I'm presenting on this morning is accessible healthcare and persons with disabilities, and I'm of course presenting the case of Trinidad. I want to start off my presentation with a look at the global context. And so there are several international frameworks that promote the quality healthcare. The Universal Declaration of Human Rights, for example, promotes adequate healthcare among all people. We have the 2030 Agenda for Sustainable Development, specifically its Goal 3, calls for healthy lives and well-being for all. And of course, when we say for all, this includes persons with disabilities. In addition to these, we are all aware of the United Nations Convention on the Rights of Persons with Disabilities. Article 25 of the convention calls for access to free health services for persons with disabilities on an equal basis with others. So we have all these frameworks supporting quality healthcare for persons with disabilities, but we all know the reality is quite different. So sticking with the global context, what I'm going to do is go through some graphs for different countries. And these graphs, of course, are based on data that was available. So they're only based on some countries. Unfortunately, the Caribbean islands are not featured in them, but it's very important for framing my presentation. So the first graph is based on 37 countries, and what it does is presents information on the percentage of persons who had unmet healthcare needs by disability status. And the information tells us that more persons with disabilities compared to persons without disabilities had unmet healthcare needs. And in some countries, the disparity in numbers was actually higher. And this includes countries like Montenegro, Romania, and Turkey. In this second graph here for 35 countries, there is information on the reasons persons with disabilities had unmet healthcare needs. For countries like Denmark, Sweden, and the Netherlands, the main reasons persons with disabilities had unmet healthcare needs were they couldn't take time off from work, they were scared of treatment, or some other reason. And in places like Estonia, Greece, and Montenegro, the main reasons for unmet healthcare needs among persons with disabilities were related to the cost of healthcare, the location of the facility, as well as the existence of a waiting list. Here is another graph regarding reasons, and these reasons are specific to Sri Lanka. The main reasons persons with disabilities had unmet healthcare needs in Sri Lanka were related to the cost of care, the cost of transport, and the unavailability of transport. So similar reasons that were raised by Senator Morris in his presentation. What's important to note is that while there are a lot of reasons why persons with disabilities globally have unmet healthcare needs, research on healthcare barriers for a specific setting, of course, will help in identifying contextualized solutions. So that said, the purpose of my presentation is to discuss the barriers to accessible healthcare across the life course of persons with disabilities in Trinidad. So recently, Accord and we would have published a journal article on healthcare barriers among working age persons with disabilities in Trinidad. So that's persons between the ages of 18 and 64. I have also looked at the topic indirectly for children, working age, and older persons with disabilities. So what I will be doing for this discussion is drawing on all those pieces of research to present the barriers to accessible healthcare for persons with disabilities in Trinidad. So barriers are related to the healthcare system, but it's important to know that some of them also relate to social, economic, and environmental factors. The barriers I'm going to speak about during this presentation will span all 4 of these factors. I will specifically speak about attitudes as a social factor, extra costs as an economic factor, and transportation as an environmental factor. And then in the context of the healthcare system, I will share information about disability-specific accommodations and services and processes. In discussing all of these, as I mentioned, I will be highlighting findings from previous research, but what I'll be doing as I discuss each point is to provide recommendations to foster accessible healthcare for persons with disabilities in the context of Trinidad. So I'll start off with speaking about attitudes. So I think we all know that public attitudes is a very big barrier to the inclusion of persons with disabilities in mainstream society, which includes healthcare. Persons with disabilities in Trinidad reported impolite and offensive mannerisms among healthcare professionals and other staff, and this also included security personnel. They also reported that doctors displayed superior attitudes, and these varying attitudes, as you can imagine, led to discomforting situations for persons with disabilities. Persons with disabilities in Trinidad also reported a lack of urgency among their relatives when they presented various medical complaints. And what transpired as a result was that the requests to visit healthcare facilities were either ignored totally or delayed. Another aspect of attitudes emerging from the research were personal attitudes. So persons with disabilities also had poor attitudes towards their healthcare. So some persons with disabilities in Trinidad generally had a mistrust in the public healthcare system because of past experiences, and understandably so. But what this often led to was self-medication and delayed visits to healthcare facilities. Another thing under the attitude category was that persons with disabilities, when they were overburdened at work, they opted to miss pre-scheduled appointments, giving priority to work over their health. There were also negative perceptions among persons with disabilities and relatives in the context of the use of supportive devices. So supportive devices, of course, as we all know, hold the potential to support persons with disabilities in actively participating in their daily life, including with healthcare. However, because of the stigma associated with supportive devices, persons with disabilities opted to not use them, and they were also encouraged by their relatives to not use them as well. So I mentioned the international frameworks earlier, right? And one of the common principles of these instruments is the affirmation of individual worth. And when we look at the different types of barriers, what we'd notice is that this principle is absent. The affirmation of individual worth. To improve attitudes generally, professional development on customer service is recommended. The adoption of a minimum standard of customer service among all staff regarding their interactions with people accessing healthcare facilities could improve the experiences of persons with disabilities. Some might argue that such a standard already exists, but from the experiences reported by persons with disabilities, something seems amiss. Next, for persons with disabilities and their relatives, education on the value of adequate health is required to promote urgency in addressing emerging health issues. And then lastly, for the attitudes point, as a society, we view certain devices and tools as normal, while we view others as extra or special. And a shift in perspective is needed regarding supportive devices. Tools should be seen as tools despite who is using them. I'm going to talk about extra costs next. There is a lot of research on the extra costs associated with disability, including in the context of healthcare. Even in Trinidad, research demonstrates financial strains among persons with disabilities because of extra costs. So these extra costs are directly related to healthcare, for example, medication and other services, while indirect extra healthcare costs are related to food and transport. So when medication was publicly unavailable, persons with disabilities had to buy them out of pocket. There was a case where someone with a disability had to undergo urgent surgery and the service was unavailable via the public system, and that person had to seek funds to cover its cost. In terms of food, some persons had specialized diets related to their health condition, and because of the rise in food prices, what actually translated in their daily lives is that they were unable to meet their dietary needs. And regarding transportation, persons with disabilities had to hire private taxis when they accessed healthcare services. In Trinidad, from my own research, many persons are reliant on a disability grant to survive. Also from my own research, the value of the grant hinders persons with disabilities from meeting their basic needs. And so if the grant is unable to cover basic needs, we kind of think that its value is going to cover the extra costs associated with disability. So some measure of adequate income is needed among persons with disabilities. Now, additional governmental grants are available. However, the long and bureaucratic process involved in application and approval is a hindrance. And just to illustrate this point, let me take you back to the example of the person who needed urgent surgery, who had to end up raising funds on her own. This person had applied for one of those additional grants, but it was never approved. And the way she raised funds was through fundraisers. It was not like she had the money in her bank account or her relatives had the money to support her with her healthcare needs. She literally had to go and raise funds on her own. So again, there needs to be adequate income for persons with disabilities. Next, transportation is a barrier to accessible healthcare. Senator Morris mentioned this in his presentation. In the context of Trinidad, for research I would have conducted with working age and older persons with disabilities, parents of children with disabilities, and disability organization managers, the importance of transportation as an indicator of well-being among persons with disabilities was highlighted. What was also highlighted in the findings is that transportation was a barrier to disability-related healthcare, general healthcare, as well as therapy among persons with disabilities. So there were reports of limited transportation in rural areas, as Senator Morris would have highlighted in his presentation, and high cost for transport was also an issue because, again, the option they had was to hire public transportation to be able to access healthcare services. I spoke about attitudes as a social factor on its own, but it emerges here under transportation as well. And how it emerges is as attitudes among taxi drivers. So persons with disabilities reported that taxi drivers did not take the time when they were dropping them off so that when they step out of the vehicle, they're not stepping into the road or a drain. And so that was one of the complaints that they had with regards to taxi drivers and how they were treated by taxi drivers. Now, overall, linked to a point that I made earlier, the underlying issue regarding transportation services for persons with disabilities is that these are often viewed as a social welfare provision rather than as a fundamental human right. And again, a shift in perspective is required to ensure that the basic need of transportation, it is a basic need. A shift in perspective is needed to ensure that this need is met among persons with disabilities. In the context of disability-specific accommodations, I'm going to speak about two things, the environment and awareness. At the healthcare facility, which is no new piece of information to anyone, the entrances, the doorways, the corridors, and bathrooms were narrow and limited access to persons who use wheelchairs. They also had no tactile markings to support the movement of blind persons or persons with visual impairments. In addition to the physical components of the environment, persons with sensory disabilities were affected in several ways. So one, blind persons or persons with visual limitations had no access to signage, and then prescription and other materials were unavailable in alternative formats. Two, for deaf persons or persons who were hard of hearing, there were no sign language interpreters or staff with sign language skills to support effective communication. And then thirdly, both types of sensory disabilities were affected overall in the context of a universal system to track the order of visitors during the waiting process. So when the waiting process involves calling patients' names, deaf persons or persons who are hard of hearing were affected, and while blind persons and persons with visual limitations were affected when a ticketing system was used. And what happened in both cases is that these persons actually missed their turn and had to wait longer. I'm going to speak about processes in a while, and long wait time is going to come up. It's already long to wait. It's your turn at the healthcare center or healthcare facility, and with them missing your turn, that wait time becomes longer. Overall, what's needed is an upgrade in healthcare facilities to support healthcare access among persons with disabilities. And from the examples I shared, it is quite clear that accommodations suitable for people with one impairment type might affect people with another type. So what's important here is consultation with persons with disabilities to ensure universal access. In terms of awareness as a disability-specific accommodation, staff had a general notion that persons with disabilities were unable to operate independently. So persons who visited facilities alone will almost always ask if they had someone accompanying them. Of course, the person who was accompanying them was seen as a means to facilitate smooth communication and smooth movement throughout the facility. There was a case where a deaf person tried to communicate via writing, but the healthcare staff was unwilling to read the response and to reply via writing to that person. This is very telling that too often persons with disabilities are expected to conform of the social expectations rather than adjustments made to accommodate their needs. And again, this is linked to an earlier point that there is a need for society to accept differences among everyone and to accept that the concept of normal does not exist. Of course, training with healthcare professionals and other staff on acceptance of differences among people is needed. So coming to the last set of barriers, there were many services lacking at healthcare facilities. These related to persons with disabilities. Senator Morris in his presentation spoke about the lack of specific programs for persons with disabilities. And one of those things relates to proper diagnosis. So many persons with disabilities, and this is across all age groups, they actually lack a proper diagnosis for their condition. And this is hindered by the absence of services and incompetence among healthcare professionals to provide information in a timely manner. Another service that was lacking for persons with disabilities was therapy, specifically physiotherapy. In some cases, the service was unavailable in the public sector, it was too costly in the private sector, or it was located in an area that didn't allow for nationwide access. Another thing that came up in the context of therapy was that information on these services was absent. I spoke about attitudes regarding supportive devices in the earlier point, but what's important to note here for persons with disabilities of various age groups is that there was a deprivation of supportive devices among them, and this was due to the high cost, unavailability, and again, lack of information about these devices. So overall, an expansion of these services at the healthcare facility is required to meet the needs of persons with disabilities. Persons with disabilities were also affected by a lack of general services at the healthcare facilities, for example, cataract surgeries or blood tests. And so the result was that persons with disabilities, one, either remained without treatment, two, paid for specialized treatment, or three, used services outside of Trinidad and Tobago. And the latter two, of course, you could probably recognize as additional cost. In terms of processes, these related to scheduling appointments, recording and retrieving patient information, receiving guidance, and the waiting procedure. To schedule an appointment, the process was long and bureaucratic, and the option to make an appointment over the phone or even online was non-existent. A paper-based system is used to record and store information, and this, of course, contributed partially to the long wait times. And what also transpired was missing and misplaced files as well. Long wait times, as I mentioned before, are related to you actually visiting the facility for a service, but it is also related to appointments. And there was an instance where this older person with a physical disability, he went and he presented an eye issue to the doctor, and his return appointment date was 13 months ahead, 1-3. And of course, those long wait times could lead to worsened conditions. So something needs to be done in terms of the long wait time for various services. In my co-authored publication, I mentioned about the recommendation was for a nationwide digitalization of the healthcare system in Trinidad. Digitalization, of course, is viewed as a key component in strengthening people-centered healthcare. And there's a lot of benefits to digitization of the healthcare system and the creation of e-health systems, right? These include easy access to medical records by both the patient and the healthcare professional, increased personal health literacy, the use of e-prescription and electronic referral services, and the electronic reservation of appointments, which was an issue that was highlighted among persons with disabilities. Digitalized systems also allow persons with disabilities to actively participate in the healthcare system in creative ways. So more reason to digitalize the healthcare system. So in wrapping up, what you would have heard is that there were overlap of the barriers across social, economic, and environmental context, as well as the healthcare system context. So what this means is that improved healthcare access requires concurrent resolution of the barriers presented. But overall, there were two main themes emerging from the discussion. The first is the need for a national attitudinal shift towards persons with disabilities. This shift involves recognizing the inherent dignity of persons with disabilities and that adequate healthcare is their equal right. Along with that shift, what needs to happen is that any tool or service that they require needs to be regarded as a provision associated with their right rather than as a special accommodation. And then the second theme is related to an upgrade in the healthcare system. This includes a physical upgrade, an expansion of services, professional development among staff, and then the creation of e-health portals to ensure all persons with disabilities can achieve adequate or quality healthcare. And again, just to emphasize, importantly, what goes hand in hand with that second recommendation is consultation with persons with disabilities to ensure that the upgraded systems meet their needs. And so that brings me to the end of my presentation. I thank you for your time, and I look forward to the question and comments. Thank you.
Thank you very much, Dr. Parry. You have joined Senator Morris in that select group of timekeepers. You did very well. And you focused on, you continued. And as a matter of fact, I should say, listening to both presentations, it shows the authenticity and the importance of doing good research, using the correct methods and everything else, because you your research, although it is done in Trinidad, and Dr. Morris is done in a number of the Caribbean islands, they're basically saying the same thing. The need for a shift towards policy and other operational issues to ensure that persons with disabilities have the quality health care that we're talking about. And I'm happy for this conference because we're hearing these research findings, and these are things we didn't know before. We experience them every day, but in terms of scientific research, we are hearing these things, and now we have more research on persons with disabilities in the region, which we can use as tools for advocacy with CARICOM and our own governments. Thank you very much. Now we move to the next session.
No, man, question and answer.
Oh, I'm sorry. Question and answer. Maybe I didn't have breakfast this morning. Question and answer. Any questions? You can open your mics. You can. Any questions in the chat? Anybody want to change the chat?
Hello. Yes, I have a question.
Okay. Could we hear it? Could you just say your name so that
sorry. Yes, Dr. Camille Alexis Garcia.
Okay.
So I have a question for Dr. Parry. So a very interesting presentation, but you mentioned attitudinal shifts, and attitudes are notoriously difficult to change. And I'm just wondering, in terms of your research, are there any suggestions as to how you think this shift can happen?
Thank you very much for the question. Very, very good question. And actually, so there is research being done on that, unfortunately not in the Caribbean. But from my own recommendations in the co-authored paper that I mentioned, one of the things that we came across is the use of an art practice to make changes. So the person who advocates for that, the scholar, they mentioned that the shift needs to be very deep, and the only way to facilitate that deep shift would be through art practice. And so that's the recommendation in the literature so far. But again, to be able to make other suggestions, I would have to rely on the literature for that, which I'm unable to do right now. Thank you.
All
right.
Give you some support here, Dr. Parry. Because if we are going to change attitude based on international best practices, there has to be consistent public education directed at the particular issue. And I mean, what we have seen across the Caribbean in terms of the practice where public awareness campaigns relating to persons with disabilities are concerned is very sporadic. And, we have it largely around Disability Awareness Week in December, and other special days, but after that it falls off, and so there is not a consistency. I mentioned and spoke to the fact that you have years of negative attitude towards persons with disabilities that are deeply entrenched and supported by, buttressed by the charity and medical models of disability. And so for these to change, you have to have a sustained public education campaign, not a 3-month thing, not a 6-month thing, but something that is sustained. In Jamaica in the 1980s, there was a family planning campaign entitled "Two is Better Than Too Many," and it was geared towards the containment of family sizes and so forth, right? And it worked tremendously. You know, it's that sort of campaign that is sustained over a period of time that is needed. And then you're going to have the other policy and legislative mechanisms to assist in that regard. You know, the training that needs to take place amongst medical professionals, which is critical, because in the medical institutions, their focus primarily is on the curing of the disease that is impacting on the person with disability. And if they don't cure the disease, I mean, they don't see that person with disability as being functional in society. And we have to change that mentality amongst the health professional to the point where they understand that, yes, Floyd Morris might have glaucoma that contributes to his blindness, and Floyd Morris is unable to see. But notwithstanding us not having a cure for glaucoma, Floyd Morris can still function, because it was that attitude in the 1980s when I developed glaucoma that contributed to me graduating from high school without a single subject. If those doctors that were treating me said to myself and family and the teachers at school that this is a profound problem and we are not able to cure it, but he can still function if you get him into Salvation Army School for the Blind, or if you get him into the Jamaica Society for the Blind, where he can learn to read and write Braille and etc., he will be able to go through the education system. It never happened that I graduated from high school without a single subject. Gloria said, I don't spit it does. But the fact is that, you know, that sort of information is needed amongst the health professionals so that they can share it with individuals with disability. And again, I keep on emphasizing that there is need for a shift from that charity and medical models are relating to disability to a more progressive human rights social model approach to disability.
Thank you very much for that intervention. Any other, and thank you, Dr. Alexis.
Good morning, everyone. This is Dr. Kamaraj. I have a question for Dr. Parry. I was wondering if Tobago was included in her study.
A question, but unfortunately no, because of the resources.
Mr. Callum.
Thank you for your question.
Okay. All right. Thank you. I hope that in the future that you'll be able to include them.
Definitely. With all my pieces of research currently, yeah, Tobago is being included. So definitely in the future. Thank you very much.
Wonderful. Thank you too.
The monitor, I know. You know that. Mandalo.
Hello, I'm Louise. I would like to raise a question. Can I go ahead, please?
Go ahead, Louise.
Okay, thank you. Good morning, everyone. I appreciate what you have been doing, and I've been with you since yesterday. However, this is a part of the health I'm going to talk about, which I did not hear much on, but because I have a physical challenged daughter who is now 25 years old, and she's unable to help herself. Right now, she's in the kitchen playing around the table with her hands, trying to use her hands that she cannot use properly. However, it is the dental part of the health I'm talking about. I haven't heard much about it. My daughter for her to get a proper dental care, I have to take her to a private doctor. And I have to make sure I have at least $260,000 on hand. Even if it's a little less, it's not much less. And she has to do anesthetic because she cannot settle herself. So I have to pay for the doctor to do anesthetic and pay for the dental work. How many people can do this? It's very difficult on my pocket. It is real. I am a retiree. And it goes right into my pension fund to maintain this. It's not easy on my
there will be you mentioned that you did not hear anything on dental issues. There will be a presentation on that about 3:30 when you can raise this issue again. But I can also ask you, before we move on, if your daughter is registered with the Jamaica Council for Persons with Disabilities.
Yes,
is
she
your
does.
daughter?
Yes, she does.
Well, there is a program for support, maybe not the amount that you're paying now, but there is a program for support through the council that can assist with the dental costs. So maybe you need, not maybe, you need to.
I don't want to raise that on the meeting, but that's another story.
I know the story, but I think we still have to persist.
Yes.
Changing times, and we hope it will happen. Okay.
It's
So
difficult. I took the
disillusioned.
receipt to them already 1 year ago, so this I don't go back.
Discuss it. We can discuss it. You can call the office or call the council, and we can discuss that further. But the truth is, don't give up on getting that kind of support. Okay.
I appreciate
All right.
that.
Any other question?
No,
Beverly
that is
Reynolds.
Okay, so thank you very much.
Thank you and good morning. Another question. I just wanted to let you know that in the chat, Kay-Ann Booker, she was asking, would introducing, this would have come after your response, Senator Morris. She asked, would introducing disability awareness into our school curricula help?
Yes, Bev, and thanks for bringing that comment to our attention. And most definitely, that is the sort of sensitization that is needed. You see, we have to start the revolution by presenting persons with disabilities in positive images throughout the Caribbean. You know, how many individuals, how many children in the Caribbean know of a Sarah Martin Newland? And I'm raising Sarah because of, you know, in the Jamaican context, because I can say, you know, in Barbados, how many individuals know of Kerry-Ann Eiffel and all the things that she has accomplished there, you know, in terms of politics and education. In Antigua, Aubrey Webson, one of the first persons with disabilities in terms of the international diplomatic arena from the Caribbean. And get these into the school curriculum so that people can see persons with disabilities in a positive light, because they have been brought up on this negative imagery that people with disabilities, all them do, they have a shed pan and they go out on the street corner and beg. Or persons with disabilities must be seen in a decrepit manner. They are in tattered clothes all over the place, etc. That imagery need to be changed. And you've changed that by putting those persons with disabilities who have done well across the spectrum in the limelight in the education system so that people can understand that you can have a disability, you can be deaf, but you are still able to function. You might be blind, but it's not your brain that is blind. You can operate in the classroom just the same.
Thank you, Senator. Any other questions, comments?
Point that Senator Morris just made.
What's that?
This is Bipaya. Just want to add to your comment, Senator Morris, in terms of your reply to the question. So in some contexts, there is curriculum already that is specific to acknowledging differences among people. I do think the issue in some cases would be the implementation of that curriculum, and therefore the bigger issue attached to that would be professional development among the teachers, because you can have the curriculum, but if the teacher themselves have negative attitudes or aren't aware of how to facilitate the kind of discussions that need to happen in the classroom, then the shift is not going to happen. So attached to change in curricula, in some cases, inclusion of the material in the curriculum, there is also a need for professional development of teachers to be able to, I won't say just teach that, but to live by example as well, so that the children who are coming up in the school system are able to appreciate differences among people. Thank you.
Any other questions, comments? Is there anything else in the chat, Bev?
Sure.
Yes, good afternoon. My hand is up.
Okay, I'm not seeing it. Go ahead.
Okay, good afternoon. I'm an educator in an inner city high school in Jamaica. And to subscribe to the matter of how this can be incorporated in the education system, we recently had a teacher that went blind. And the concept of the ministry was to send her off to the blind school. And, with my knowledge and background in special needs, in the UK, I decided that no, because I want to utilize her to help me to raise awareness about special needs. And so the counteraction was the school environment is too vile for her. But anyhow, we took the challenge on, and having that teacher in that space has really helped to cement the whole matter of inclusion in our children. I mean, the children are so supportive. It could not be a better space for her at this time. The children have grown, they have realized how to accept differences and to see differences that could happen to anyone at any time. So I think our intentions now are good, but I think we need to reach out to the ministry where they will make the decisions, where they will write the policy of how to incorporate differences at all levels. Because when you look at the Disability Act and the EU Convention on the Rights of the Child, parents now are demanding that their children are educated alongside their peers. And there's no way we can deny that. When we look at how our schools are constructed, there is no avenue for persons in a wheelchair. The classroom door is not wide enough to accommodate that. The bathroom facilities are not accommodating to special needs. And when we have to look at a situation now because of the LGBT or whatever it is, when a child comes to school now and say, I want to be in the female bathroom because of X, Y, and Z. Look at the case with Kester Semenya, the athlete. How are we going to meet those needs? So I think there should be now a very proactive approach in the way we facilitate special needs, not just on paper. I think we are doing trial and error at the moment, but I personally would like to avail myself on some of these committees to actually situate how some of these activities can facilitate our people and facilitate our people in a beneficial way. Thank you very much.
Thank you very much, Carmen. Thanks a lot. Any other comments or any of the presenters want to respond to? There's somebody?
Yeah, but
Oh, Keisha. You want to respond to that? Okay, before you, Keisha, one of the presenters want to respond to Carmen.
Yeah, you know, Carmen, very good observation. And, you know, inclusion is a part of the new paradigm, and it's a part of the human rights model of disability. And most definitely, you know, you cited the example about inclusive education. That's not our focus this year, but we focus on it in 2020. And definitely, you know, that is what we are pushing for. Students, children with disabilities must, as far as practicable, be in the same educational institution as those without disability. The Convention on the Rights of Persons with Disabilities is saying only in exceptional circumstances where you have complicated and complex types of disabilities, that special education is relevant and applicable. But apart from that, a person who is deaf, person who is blind, person who has physical disability, put them in the same classroom, because that is how we're gonna change the negative attitude towards persons with disabilities. I hear people tell me about Gloria Goff and her exploits in the same educational classroom. She here miserably up herself enough, but she don't know if it's positive or negative things the people tell me. But that's another story. But the mere fact that she was in the same classroom with them created an impact, so that people understood that she, a person with a disability, can sit and perform just as well as anybody else. And that is what we are pushing. Inclusion, participation, non-discrimination.
Thank you very much, Senator. Now let me hear from, and this is our, I'm sorry, because of our time, after Dr. Bowler, we can take no other comments. So our questions. Dr. Bowler? Bowler Hines. She ain't coming on. Is she there? Is she there? Okay. All right. I think my comments also in terms of what Carmen said, was looking at the bigger picture. I think Senator or Dr. Parry mentioned the idea of highlighting persons who are doing well or who are achieving. And I think what it speaks to for me in terms of Carmen's comments were that we still need to be focusing a lot on those in the positions to make the decision, because this idea of seeing the person with the disability as different, it speaks to all sectors of the society. And here is a teacher qualified, and because she has gone blind, no alternative is sought than to say that she cannot function, or she has to go to the school for the blind, even as an adult. So that speaks to, but I want to thank
before
is this Dr.
Bowler Hines, yeah, she's asking if she can be unmuted, please. She can't do it herself.
Oh, okay.
She will need administrative support to unmute her.
But you can't unmute her?
Oh, wow.
Chevelle, can you unmute Dr. Keisha Bowler-Hines?
No one is able to unmute a participant. They have to unmute themselves, but she has the freedom to do so.
I think that she's not able to. I don't know why.
Must be something to do with her. She has to click the prompt.
Granted permission. The host has not granted permission.
She has the permission now.
She's getting the message that the host has not granted permission.
She's getting the message that the host has muted her.
Okay, no, I thought it was something.
She's getting the message that the host has muted her. All right. Dr. Hines, if you're hearing me, I hope, we really are interested in hearing your comments, but we have to move to the next session. So I'm sure the important point you want to make can be made during another session, even if, because we're dealing with health. So it can be made.
Oh, and we can answer.
As well as you can send it in the chat and it can be addressed. Thank you very much. So our next session is going to be led by Mrs. Beverly Reynolds, and I'll now hand over to her.
Thank you. And from my side of the world, it's good afternoon. And from yours, it's good morning. I have to pause here to just say how this is like a great meal. Yesterday and today, and so I just want to commend again Dr. Morris University of the West Indies and everyone who's been presenting so far. Yesterday you would have heard Yesterday, you would have heard from Dr. Paula Dawson, but I still would like to introduce her. Perhaps there's somebody here today who wasn't here yesterday. So we have two presenters in this session, Dr. Paula Dawson and Dr. Theresa Bent. Let me introduce Dr. Dawson. So Dr. Paula Dawson, who will be speaking on spasticity management of patients with neurological diseases. She is a consultant physiatrist, and she explained that yesterday. It's a merging of physical medicine and rehabilitation, physiatry. She is, I think, the first one. She's been pioneering that in Jamaica. She's a founder of the Rehabilitation Institute of the Caribbean. As I said, she's a pioneer of physical medicine and rehabilitation physiatry in Jamaica. She's a lecturer in the Faculty of Medicine at the University of the West Indies, a consultant at the University Hospital of the West Indies, and a co-founder of the University West Indies Sports Medicine Clinic. Dr. Dawson holds the distinction of being the only physician in Jamaica with US board certification in physiatry. She received her medical degree in 2000 from the Faculty of Medicine at UWI after obtaining an honors bachelor's degree in the double major of biochemistry and zoology. In my days, they would call her a brain box. She did residency at Long Island and Jewish Medical Center, North Shore, Albert Einstein College of Medicine, and then completed fellowship in interventional spine, muscular, skeletal, and sports medicine rehabilitation from the prestigious Northwestern University Rehabilitation Institute of Chicago in 2008, just before she returned to Jamaica. Thank God you came back. Dr. Dawson is a team doctor for, I think this is the Jamaica Athletics Association, JAAA. She's also one of the team doctors at the JFF. I'm sorry, I'm not quite sure what that one is. She has received numerous awards, including being selected as an award in 2018 for UWI 70 Plus Outstanding Women, UWI 170th Anniversary, 2012 nominee for National Disability Award, awardee for Jamaica in 2012, 50 Most Outstanding Jamaican Women, and it is quite a prestigious bio. Dr. Dawson has a passion for patient care and works continuously to improve patients' functions within their physical ability. She's a born-again Christian and a gospel vocalist with Transformed Life Church. That's what I missed yesterday. I know I heard something about a vocalist. So I am going to ask Dr. Dawson at this time to make her presentation. And after that, we will move to the second presenter. So spasticity management of patients with neurological diseases. Thank you, Dr. Dawson. Over to you now.
Hi, good evening or good afternoon, everyone. I am glad to be here. It is interesting because on the schedule, I thought I was at 12:30, but I think it's a misprint. So I'm here to start the presentation. But so thank you very much. All right, so I'm trying to minimize this screen. So can you guys see my first slide? Yes?
Yes. Yes.
All right, wonderful. I want to move this away, out of the way. Oh, there we go. Okay. Come on, behave yourself. I'm trying to get this to go into full screen. Why doesn't it go? 1 second, please. I'm trying to go into full screen. Oh, I'm going to stop sharing and start again, please. Go back into. It says I can't do that. I'm not so sure why I can't go into full screen. Let's see if there's a text box open. 1 minute, please. Minimize everything.
I see something on your screen saying enable content. I don't know if that would help when you brought up the presentation.
No, I think there's a text box open. That's probably what it is. Let's close it. What? It keeps beeping. I don't know why. Let's close this one. All right, let's close everything.
And someone is saying click enable content and try again.
Still giving me that. No, normally when I hear that sound, there's a text box open. No, I don't want to leave the meeting. All right, so let me just present as is. I'll just present as is. Let me just go back. I'll present with the box at the side. I don't know. Seems to have two Zoom meetings open. That's probably the problem. All right, I'm just going to present like this. All right, so let's cancel that. Technology, right?
Dr. Teresa Bent on. Oh, she's not on as yet. Okay. Please bear with us.
Thank you. I was trying to ask you, can you unmute, undo the video clip? Thank you very much. My apologies for that, guys. I'm still mastering this thing. Okay, so we're gonna start now. I had a text box open. I think that's what happened. All right, wonderful. Anyways, don't know why it's getting disrupted. Anyway, so sorry about that, ladies and gentlemen. Good morning. I'm just gonna jump into it. It's not progressing. What's wrong with my computer today? It's not progressing through the slides.
Did you try slideshow?
That's what I keep clicking on slideshow. It keeps making a beep, which makes
Okay,
it sounds
so
like
I'm seeing a little box that says enable content. And what if you were to click on that?
No, I usually don't allow. I usually don't use that at all.
Oh, it says something about media. I can't read it too well, and something being blocked. Right in that same section, below that, yeah, there's security warning, something about being blocked, and then it says enable content. I don't know.
Right. I think the technical guy just took control of my cursor, but I think I must have a text box open, which is why I keep hearing that content. It won't even progress.
Would you be able to manually, instead of the slideshow, just move from slide to slide in this format, even though it's not?
That's the thing. It's not giving me that option. I keep like there's a text box open. Oh, what's going on? I'm gonna let me. What's happening? Let me open all of my things at the bottom to see if there's something is open that shouldn't be open. I'll close everything. All right, so let's try again. You guys can see that, but it's not progressing. That's the problem. It's not progressing. All right, guys, I'm gonna sign out and sign back in and close everything on my computer and come back, because I think that might be the only way, because I'm not able to progress the slides.
Okay. In the time, again, I'm asking if Dr. Teresa is in, perhaps we could go to her. Is she? I think the last time I'm told she wasn't here as yet. So we'll just wait. Okay, we'll wait then. Good things come to those who wait, eh? Let's see. I was actually trying to see if I could find in the chat what Dr. Keisha Bowler was saying, but I'm not seeing any text here. Let's see. Oh, yes. While we're waiting, folks, I'm just reading what Dr. Keisha Paula, is it Hines, was trying to say previously. She says, awareness raising about persons with disabilities must be supported by an engendering culture of care and compassion. It is not enough to know. We must move to take action. And Bonfembrenner's bioecological model presents a good framework for training, as it speaks about the importance of interaction among and between various systems at different levels in the environment. She says, I'm in full support of a public education campaign, but this must be complemented by the requisite training across all sectors, not select groups such as medical personnel. So thank you for that contribution to the previous conversation. We wait. Well, we're at a different slide now. What does this mean?
Oh, Jesus. I think it's something with the Zoom because I completely copied my entire presentation and it worked on my computer, but it's not advancing in Zoom.
Okay.
I don't know what.
You're able to move the slides at your end. All right. Well, I think, okay. And are you still able to do that?
No, once I open Zoom,
you can.
let me stop sharing and see.
Mm-hmm. I know it might be challenging because, you know, it's so much better when we can see as well as hear, but we really don't want to miss what you have to say. And I was just wondering, given the challenge that we're having here, if you can move the slide from your end, perhaps you can still take us through.
Once I'm signed in to Zoom, it doesn't move at all.
Oh, wow.
Doesn't move at all.
Dr. Morris, is there anything that the persons from your technical people can help us with here?
So when I try to screen share, two PowerPoint opens, one black one and one with my PowerPoint, which is unusual. I don't usually see two PowerPoint when I try to screen share. We try again. Can't go to.
Right click in a space.
Pardon?
Please right click on one of your slides.
Yeah, but I get that funny sound when I right click on the slide.
When you
box is open.
When you click share screen, what are you sharing? Your screen itself or the PowerPoint individually?
The screen that has a PowerPoint in it.
All right, try sharing the application itself instead of the screen.
Okay, to do that now, because I don't have control over anything. Once I go into Zoom, I'm gonna have to sign off completely. Everything I try to engage, I get that little sound that says a text box is open.
Can you share the PowerPoint with someone else and they just share it while you...
Maybe I can email it to you.
All right, check the chat and you can email it to that address.
All right, but I'm gonna have to sign up completely because I can't access anything once I'm signed in. I'm gonna send it to you now. Once you send me the email address, let me write it down before I sign off. I'm waiting for your email. Thank you.
Yes, sorry. Good afternoon again. Bev Reynolds,
Yes.
are you still on? I'm suggesting that in the interest of time, and we don't want to keep the participants online, not doing or hearing anything. So we could use this time while we wait to facilitate any questions that the participants want to raise in terms of the health sector, any experiences they want to share.
Great.
So could you just facilitate that on and see what happens? Because this session really goes up until 12:30.
Right.
Until Dr. Dawson comes back or Dr. Ben comes on.
Ben, yes. Okay. Great idea. So you've heard. Now is the moment that some burning questions or comments that you may have wanted to contribute, whether it's what you've heard today or since yesterday. Just raise your hands, please, and we will do that at this time. One thing I know I would like to say from out of yesterday, that had to do with the presentation that looked at what was happening in Montserrat and the fact that some of the overseas territories really, they've not, because of who they are, where they are, they have not signed on to the UN declaration. But I wanted to flag yesterday that this is where really the CARICOM rapporteur on disabilities, the work of the CARICOM rapporteur on disabilities, special rapporteur on disabilities, which you know is Senator Dr. Floyd Morris. This is the opportune time and place for us in the region to address that. It doesn't negate the responsibility of the mother countries of these territories or the oversight countries, but it definitely offers that opening for us in the Caribbean to do that. And a lot of what has been discussed so far are within the clauses of the clauses of the Pétionville Declaration, which is a part of the framework for the CARICOM rapporteur's work on disabilities. And I just wanted to flag that yesterday. I see Dr. Dawson is back with us. Anyone else has anything that they would like to flag at this time or add?
On Sunday, we have to put $1,000 for transportation.
But somebody here said it earlier, and I think that's where you guys got to be careful with, that this is not an attempt to drive up.
We're getting
like
somewhere.
Start out with a 20 now and then, because he's been having conversations with a whole bunch of people out there.
Mr. Mills?
A conversation, he'll bring the concern to you.
Hello, Mr. Mills.
Pete.
Would you mind muting your phone, please?
I'm sorry.
Thank you. Dr. Dawson, it looks as if we might be able to go now.
Yes, please. My apologies. Sincere apologies.
We do
Sincere
understand.
apologies. All right, so let's jump into it. Spasticity management. Now, the question is, what is spasticity? Now, spasticity is the stiffness that we see in neurological diseases, for example, children with cerebral palsy, people with spinal cord injury, or people with stroke. They tend to have a stiffness that stiffness is velocity dependent. And what does that mean? The stiffness is more seen when you try to move the limb fast. The faster you move the limb, the more you get that pull back. And it's a pull to movement. So it's hyper excitability of the stretch reflexes. These people, when you try to do the reflex, they kind of jump. They're very jumpy. There's a difference between spasticity and increased tone. An increased tone is resistant to passive stretch. For example, if you were to get an ankle injury and you're placed in a cast, God forbid, for 6 months, when you take the cast off, your ankle would be stiff. That is increased tone, or if it's really, really stiff, that's hypertonia. That is different from spasticity, because spasticity is resistant to the movement, and it's a function of hyperexcitability of the stretch reflex because of whether it's a brain injury or spinal cord injury. And rigidity is you can't move the area at all, just to define that. So what happens in spasticity? When there's a central nervous system issue like a brain injury, stroke, tumor, infection, encephalitis in the brain, cerebral palsy, or something in the spinal cord, for example, spinal cord injury, transverse myelitis, any form of spinal cord insult, you are going to lose the control. So the central nervous system control or excitability of the move of your movement. And essentially, there's a reflex arc. When you send information into the cord, and information comes out from the brain and it kind of quiets it down. But if we lose that control, you will have the reflexes of being hyperactive. So it's an abnormal motor control due to an oculomotor neuron lesion. And an oculomotor neuron is anything in the brain, anything in the spinal cord. A lower motor neuron is everything else in the periphery, right? Everything into the arms, into the legs, into the bowel. But the central nervous system is the upper motor neuron. So you lose that descending control. So what happens with these people? They tend to get a lot of stiffness. They get flexion at the wrist that you can't move, a finger in the thumb, especially in some stroke patients. You get elbow flexion in the upper limb. In the lower limb, you can get a tight knee where you can't extend the knee. You can have a foot drop, meaning the patient cannot bring the foot to 90 degrees, or you can have an equine varus where the foot kind of turns in and you can't straighten it. This is what happens with spasticity. Now, the problem with spasticity can be painful, it can be uncomfortable, and it can decrease your function. Here's a picture of someone with a right-sided stroke weakness, and down in the leg, you can see the foot is turned in, right? You can have contractures or disfigurement, which can affect the movement. It can interfere with nursing. It can give them a pressure ulcer, which we call decubitus ulcer. It can affect your hygiene. I have had patients where a woman once had a baby and she's not able to open the child's leg with cerebral palsy because they're so tightly locked together, right? You can have bony fractures. In addition to that, you can have subluxation, or you can have dislocation of the joint itself, where the joint pulls out of the socket. And there's something called heterotopic ossification, where there's bone formed around the joint, and we're not supposed to have bone around the joint. And it can also affect the nerves in the periphery and cause peripheral neuropathy pain. However, spasticity can be good. Yes, it can be good. Why? How does it work in a positive way? Well, if someone has a stroke or spinal cord injury, their legs will be weaker. If they are stiff in the legs, in the standing position, that stiffness can help the therapist to hold them up. Because if the legs were floppy, standing them up, they'll just flop down. but with the stiffness in the leg, it will tend to hold them up. So when we're working with the physical therapists and the occupational therapists, we work in tandem. We don't take away all the spasticity. We allow some because it can help in ambulation and it can help in transfers. And it also helps to maintain the muscle bulk. Because the muscles are constantly contracting, it tends to keep the muscle bulk at a particular size. You can have prevention of deep vein thrombosis, which is a clot in the leg because the muscles are always contracting, and you don't have stasis, meaning slowing of blood flow in the legs. It prevents osteoporosis. And for those of you who know, osteoporosis is thinning of the bone to the bone where the bone may fracture. Now, because the muscles are always contracting, the stiffness in the muscle, that kind of stimulates the bone, and the bone density is preserved. And it can be used as a diagnostic tool. What do I mean by that? If a child with cerebral palsy has spasticity, or someone with a spinal cord injury has spasticity, and you know that the spasticity has gotten worse, it can suggest an infection in the lungs or the bowel or the bladder or some respiratory illness. So it can be used as a diagnostic tool. So whenever there is increase in spasticity, you can use that if there's a possibility that there's something else going on. So how do you treat this? Multidisciplinary approach. You know, I'm a multidisciplinary girl. You have the physical things that you can do. There's medications we can do. And of course, there's psychological things. So it's a team approach. The physical measures, stretching, positioning, make sure you put the patient to sit properly to avoid the deformity, splinting, similar to the splints we used yesterday, strengthening exercise for those muscles that you can strengthen, education, you can use walking aids, electrical stimulation. But in terms of medical management, there are a lot of drugs that we use, and I'm getting very good results with drugs, including baclofen and even the CBD oil. We're about to do a study on CBD oil use in Jamaica on children with cerebral palsy working on their spasticity. There's another type of treatment that we're pioneering here at UA, which is injection with a medication called phenol, which is an alcohol. The BTX in this slide is Botox. We definitely use Botox, especially in the hand. I'm going to talk about Botox use. And then you have some medications that we put inside the spinal cord area called the intrathecal, where we can put the phenol and baclofen, and of course, orthopedic surgery. And there's another neurosurgery called rhizotomy that we can do. But we should not forget the psychological measures that we need to put in place, which will include adjustment of disability and self-management. So, algorithm. I'm a physiatrist. I always have an algorithm. You start low, you go slow, and you gradually increase your intervention. First thing, prevent the complication. Second thing, include the parents, family, and the caregivers. Education. Third thing, physical modalities, for example, the bracing that we can use. Then if that doesn't work, because remember, you have mild spasticity that you may not even need medication. But then if the 3 steps don't work, then we can move on to pharmacology, which is medication like baclofen, a diazepam, which we know as the Valium, and CBD oil. Chemical neurolysis, which is nerve block, where we actually use an electrical device and go right onto the muscle where the nerves meet the motor point, and we actually burn the nerve. Yes, we do. We burn the nerve in a controlled environment to take away the spasticity, and we have fantastic results with that. And of course, if all else fails, you may need surgery. Now, local anesthetics. So when we're going to inject now, we can inject with local anesthetics. We can use lidocaine, which is similar to what you use at the dentist, or bupivacaine. The difference between them is just how quickly it starts working and how quickly it wears off. Lidocaine, onset is quick, but it wears off quickly. Bupivacaine, onset is slower and it wears off. Take a longer time to wear off. But what we use is something called phenol, which is an alcohol, and botulinum toxin. These are different types of anesthetics that we can use. At the top, where anesthetics only minutes, doesn't last long. Alcohol is a little bit longer, but phenol can last up to 3 months. In some instances, we do it every 6 months, and botulinum is as well 3 to 6 months, which means we have to do it again. As I mentioned to you before, phenol is an alcohol. The thing with phenol, it's a disinfectant. In fact, when I first learned phenol, they say if the needle falls on the ground, you can use it still because the phenol itself is such a good disinfectant. You will not get an infection. So when we're doing the injection, we only clean with alcohol, and then we do the injection. What happens? Here is a diagram. This is on the left, you see an example of the nerve. Those little gray small dots in a circle, those are the nerve fibers running up and down, not the nerve fiber, the muscle fibers running up and down the muscle. The muscle is the big unit, and these are the little muscle fibers. And so when we put the phenol on, it actually burns the outside of the nerve. Now, why would we burn the outside of the nerve? Imagine a nerve is like an electrical wire. The copper on the inside is actually the what transmit the electricity, which is the nerve impulses. And the plastic on the outside of the wire is a coating of the nerves. Now, when you remove the coat, the nerve will transmit information slower. And that's what we want, because in spasticity, it's transmitting too fast. And so when we burn the outside in a control setting, so it's painful at the time when you do it, but when we do it, the children we put them on the conscious sedation. We work with the anesthesiologist and we put them to sleep. And so we what we call demyelinate, remove the myelin sheet on the outside of the nerve in a control setting, and we get very, very good results. We use a nerve stimulating machine where literally, if the thumb is in the hand, I can use the machine and stimulate the muscle that causes flexion of the thumb, so I can know I'm stopping the movement in the correct muscle. Similarly, when I'm doing the hamstring, when I stimulate with the machine, I'll see the hamstring flickering, and I'll be able to inject the phenol. And literally, before I stop injecting, you see the hamstring, it gets less and less in terms of its movement. Here's an example of the phenol. We're doing an adductor here, and we use some electrical wires. This needle is actually an electrode. So it's connected to a machine, and it stimulates the nerve, and then it causes movement, and we know we're in the right location. So we use phenol, 5% to 7% demyelinate or axonal. It burns the nerve. We want that to happen. We want the protein to be denatured. We want to burn off the nerve to slow it down in a control setting. So we don't do the entire nerve, just a particular point. So phenol administered, injected in the motor points, so it's focal. So if I'm injecting in the forearm, it will not help the biceps. If I'm injecting in the biceps, it will not help the forearm. It is localized. The advantage of this, it can last long, right? It's widely approved. It's cheap. Literally, phenol is cheap. When we do it at UWI, we do it for free, right? Because I partner with a group of doctors that come from Minneapolis. They come 3 times per year since 2009, with the exception of COVID year. The last time they were here was February 2020. They'll be here in the end of May, the first week in June. We work with Bustamante Children's Hospital and the University Hospital. We inject over 100 kids when they come, and adults with spinal cord and stroke. We have people who are walking, who couldn't walk properly before, and people who are sitting, who couldn't sit properly before. I remember I had a patient once, a lady, and she came back and she was happy. And I'm like, why are you happy? I want the child to walk. And the child wasn't walking. And she said, me can lap her now. I'm like, what? What do you mean lap her? Before, because the child's legs were scissored, they were tightly crossed, she couldn't lap the child around her side. So she couldn't carry a bag. So she had to carry the child in front. Now, she said, because we injected between the child's leg, she's able to open the leg, lap the child around her waist, and now she can carry a bag. And it's so important that, different goals will give different satisfaction in an outcome. All right. The drawback to phenol, it is painful. So we put them to sleep and they don't feel it. And when they wake up, we tell parents to give them Panadol. The complication is it can burn, it can cause numbness, it can have hematomas, which are blood clot. But because we do it in a control setting, we draw back to make sure we're not in a blood vessel. And so these kind of complications minimal. We've been doing it since 2009. I've been doing it I don't know, over almost 20 years, and praise the Lord, we've not had any severe complication. If, however, you inject a lot directly in the blood vessel, you can have tremors, you can have convulsion and seizure, you can have blood pressure collapse, the blood pressure can drop so hard, you can have, the heart can even stop, or if you inject in the chest, you can have respiratory issue. I mean, we use such a small amount, it doesn't really affect the child or the adult. It can cause pain. After the injection, they're gonna have a little bit of soreness for about a week or two, but then that subsides, and then the patient recover. Again, if we inject directly in the blood, you can have a smoky urine. We can cause a clot locally, but because of what we do, the technical dose, the technique that we use, we don't inject. And we don't inject as much as 20 or 30 mils or cc's. We inject like 5 or 6, and that's a lethal dose. And that lethal dose has to be directly in the blood vessel, not in the muscle. And we don't go into the blood vessel. Now we go to botulinum toxin. Botox. Yes, the same Botox that we inject the face with. Botox, we have several types, yeah, but commercially available botulinum toxin type A and B. Now this is an off-the-label use because it relaxes the muscle. So Botox, as some of you may know, is from a bacteria, gram-positive anaerobic bacteria, and that bacteria produces a toxin that causes paralysis. And so if you have a cup full of Botox, you can actually wipe out the entire United States. So when you buy the Botox, it's in a little itty bitty bottle. You actually don't even see anything in the bottle. You just have like a smear of white, and then we mix it with saline and we reconstitute it. You can't see anything in there. We use botulinum toxin type A in Jamaica, and it's an off-the-label use. What do I mean by that? Botox is not prescribed for spasticity, but it can be useful, and it's used for headache. It's used for migraine in the States, and cosmetic use as well. And what does Botox do? Botox will block transmission at the nerve level. And this is a complicated slide just showing you that Botox interferes with the vesicles that are important to transmit the electrical impulse, right? We inject in the calf. You can see a picture of a calf here. When I'm doing Botox or Phenol in the calf, just 4 spots. In a rectangle, 2 at the top, 2 at the bottom. This will allow the patient's foot to come up so that they can fit comfortably in a shoe or in a brace. Summary of Botox, injected into the muscle. Duration is about 30 weeks, much less than Phenol. The problem with Botox, it costs $550 US dollars, $550 US dollars. That's a lot of money just for 1 vial. In the States, we used to use up to 2 or 3 in the arms for children alone. But it's easy to administer. It's very forgiving. Unlike Phenol, it's painless. And you can inject it without anesthesia because it doesn't hurt, right? The drawback is always transient. So after a while, you have to repeat it. You can form antibodies for it, meaning after a while, it just no longer works, right? And so the cost is a limitation. The approval by healthcare here, the insurance companies will not pay for it. There's no significant complication. The worst thing with Botox is that it does not work and you spend all that money. So it's between $500 and $550 US here in Jamaica, which translates to, I don't know, $70,000 or $90,000 just for 100 units. And we usually use 200 or 300 units. It's used along with, you must use a splint if it's your foot to stretch. We can do casting, meaning put on a plaster cast and help to stretch over time, but you must do it with therapy, whether physical therapy or occupational therapies. You must do it with therapy, or we can just put up a cast, constraint cast to prevent your movement. Here's a patient that had Botox in his elbow. It's a stroke patient. The elbow is flexed, the wrist is flexed, and his foot is in a turned in position. They injected the biceps and his hand. The arm is now down, the wrist is now extended, and his foot is straight. He's able to stand flat. A Botox, very expensive. The thing with Botox also, when they're bringing it to me, they have to carry it in a portable air condition or portable fridge, because if the temperature drops, the temperature goes above 25 degrees, the Botox toxin dies. It no longer works. So it has to be kept in a refrigerator. It's very hard to manage. Let's skip over that slide, unless that's what Botox we don't have in Jamaica. They have that in Europe. So the side effects, unwanted weakness, just like in phenol, you may get a blood clot, bruising, local redness, erythema. In some patients that have allergies, you may have flu-like symptoms. Not in the leg injection. I do Botox injection around the neck for somebody who have torticollis. We inject in the muscles around the neck. I inject around the head for headache as well. But that's when you probably get the flu-like symptoms because it's closer to the respiratory area. But in the arms and legs, you tend not to get any of these symptoms. Painful because it's a needle stick. You can traumatize the nerve. You can have dysphagia, especially when you're injecting around the neck, and you get antibody formation, which means it no longer works for you. Here's a patient, a lovely little young man. He was so flexed when we did him, and we did phenol and Botox. And after, with a multidisciplinary team, we actually got his knee out to full extension. This is him again with his knee now. So if you go back, this is him. His knees were tightly flexed under his body. His hips were up into his chest. His knees were up into his chest. And this is him extended, happy, much improved after the phenol. But this alone would not work without the therapist. And that's one of our physical therapists at UE. Here's another little boy. He did phenol in his hand. And when we asked him at follow-up, how are you? He says his favorite hobby is to walk. And when I first saw him in 2008, 2009, he couldn't walk. And with the injection, he was able to walk. This is him about to stand up. All right. And essentially, that's it. Wow. I am very sorry I delayed. I caused delay in the presentation that was going on time. I hope I didn't go too fast. I was trying to make up time. Yes.
Hello, good morning.
Hold on a sec. Morning, Teresa.
Thank you for inviting me to present at this conference today. I'm Dr. Bent, and I'll be presenting on spinal cord injury outcome and how a multidisciplinary rehabilitation approach helps.
And Dr. Bent, if you may permit me, I didn't realize I had my mic on, just so that those of us online can know a little bit about you. So she is, since completing her senior house officer year at the University Hospital of the West Indies, she has been working alongside consultant physiatrist, Dr. Dawson, who we just heard from, in the physical medicine and rehabilitation department, where she has been exposed to a wide range of disabilities and has been able to follow patients' progress during medical intervention. Dr. Bent is passionate about bringing awareness of the possible benefits of rehabilitation, and she's involved in the research of new and innovative ways of improving patients' outcomes and thus their quality of life. Thank you and welcome. Please go ahead.
All right, moving on. So the goals of my presentation is to give an overview of the classification of spinal cord injuries and to focus on some of the rehabilitation goals and objectives for the different levels of spinal cord injuries. So this presentation focuses on a case of a 42-year-old patient who sustained cervical flexion extension injury in a motor vehicle accident. Post-injury, the patient underwent emergency surgery for a C6 to C7 bilateral jump facet with spinal cord compromise. 1 week post-surgery, the patient was seen by the rehab team and was noted to have 5 out of 5 power in C7 and above, which is full power, and 0 out of 5 power in C8 and below, which is no power, with sacral sensation intact. Our action plan and outcome was to do a multidisciplinary rehab team approach with 3 to 4 hours a day, 5 days a week, with Studies have shown that initiating early intense rehabilitation provides a better outcome for patients with spinal cord injuries. And our team consisted of a physiatrist, a neurosurgeon, urologist, neurologist, physiotherapist, occupational therapist, psychologist, and nurses. And at discharge 50 days after injury, the patient was known to now have improved power 3 to 4 out of 5 in the deficit areas, which showed that the patient moved from no power to now being able to move her limbs against resistance and moving it against gravity. At 1 year post follow-up, our patient was now ambulating with a roll walker and now continent of bowel and bladder with 4 to 5 power in both upper and lower extremities. So our patient was now able to move her limbs against minimal resistance. At 2 year follow-up, the patient went back to work and was now walking with a straight axis cane with strength 4 to 5, which is basically against against resistance and with full power, and their spasticity was controlled with baclofen and analgesic. We'll now move to classify spinal cord injury based on the American Spinal Injury Association. Their umbrella terms for their classification is complete versus incomplete, and this is dependent on the sensory level, which can be the ability to feel light touch or pinprick, the motor level, which is the power of their muscles, or the pressure in the sacral segment, mainly, which is being able to feel in the perianal area. You can also sometimes look at the neurological level of injury and the zone of partial preservation. This is an image of the Asia scale, which can be brought to the patient as a printout. It's divided into the right and the left side of the body, and on each side it's divided into sensory and motor. This form has major areas in the upper and lower limb, where the upper limb is broken up into 5 segments from C5 to T1, and the lower limb also from L2 to S1. There's also a smaller area which speaks about deep anal pressure and the sensation in the perianal, the motor perianal, and the ability to feel the deep anal pressure. So in order to pick the neurological level, we look at the lowermost level with both normal motor and sensory functions. The motor level that we pick is the one that's greater than 3 out of 5 power, with the level above that being 5 out of 5, which is full power. And their sensation is intact on both sides. If there's no motor level, if there's an issue in the thorax, we will use the first intact sensory level above the level of injury. So we'll now move on to the rehabilitation goals and objectives for the different levels of spinal cord injury. So now we're starting here from C2 to C4 injuries, and these patients are paralyzed from the neck down. Rehabilitation is more focused on training the caregivers to use adaptive technologies and teaching the patients to direct their own care. So these patients, since they're paralyzed from the neck down, they're unable to move any of their hands, so they can't flex or extend their elbows or move their wrists or fingers at all. These patients are dependent for all their activities of daily living and need assistance with bowel and bladder control and for transferring from bed to chair. These patients also often have weak diaphragms as well as weak intercostal muscles, and so are often ventilator dependent. And they use power chairs for mobility as well as assisted technology. There's a picture here on my slide which shows a lady in a power chair, which can help her get around, as well as she's using assistive technology with a laptop and something that helps her with her speaking, so she can speak her commands and do what she wants on the laptop. We're now moving on to C5. These patients are now able to flex their elbows with assistance of the bicep muscle, and they can assist with their own grooming and bathing. They may even be able to feed themselves with adaptive equipment and gain functional skills with universal cuffs and plate guards. So this picture here at the end with the purple straps and blue straps, these are balanced forearm orthosis, which can be used to attach the utensils and patients may be able to eat. The patient, and these are pictures of plate guards, or these patients probably will be more comfortable with using a bowl so that when they're trying to pick up the food, they will have some resistance with the corners of the plate guard in order to pick up their food. These patients will need to be transferred with assistance, and they also would use a power wheelchair. Moving on to level C6, these patients can now do wrist extension, and with the addition of wrist extension, they have a tenodesis effect. So tenodesis is basically because they're now able to extend their wrist, pictured above, it will give the effect of them being able to close their fingers, even though they're not actively able to flex them. So with this new found ability, they can grab things and flash their wrists, and that would allow them to grab and pick things up. They can be modified, independent for dressing and bathing. And the males can now be able to do their own catheterization of the bladder in order to allow them to relieve themselves. They can now probably use a manual wheelchair, or they always have the option of the power wheelchair and may be able to drive a modified van. So pictured here is an example of a modified van where they have hand controls and they're able to, for example, twist for gas, push for brake, and there's an emergency brake in the reach of their arms. This is also another example where you can see the buttons and the different hand levers, so they'll be able to drive. So we're moving on now to C7, to the T1 level. C7 is the key level for functional independence, and they have now gained elbow extension and finger flexion. They have some functional elbow extension, and so they're able to be able to like bear a little weight and push themselves up off of the bed and transfer themselves from bed to chair independently, as pictured down here. Men can do their own bladder catheterization, and this is a picture of a tool that they can use to grab the catheter, because it's fine, and so it helps them to grip it and be able to catheterize themselves. They can also use a manual wheelchair. Now C8 to T1, they have more fine coordination to pick up things, and C8 allows long finger flexion and T1 allows finger abduction. So both men and women can now catheterize their own bladders, and they can use the manual wheelchair using a push rim. The push rim is pictured here, which is a rubber material that they can put over the wheelchair, so it's easier to push the wheels and they can move themselves around. They also have greater truncal stability and better respiratory function, so they can be more independent, and they can even work on strengthening their upper body. There's a picture here of a man in a wheelchair, and his daughter is in his lap, and he's able to carry her out to the park because he's able to move himself around. This other picture here is a picture of a man who is in a modified wheelchair, which gives him support in order to go upright. And so he's able to do things around the house, like get into the cupboards and maybe even prepare his own meal in the kitchen. Moving on to the lower limbs with lumbar paraplegia, these patients who have L2 function can now use their iliopsoas. The L2 allows them to do hip flexion, but they're still not able to straighten the knee without the quads. These patients will need something to stabilize the knee. As pictured here, we can use the knee, ankle, foot orthosis, also known as KAFOs, which is basically a brace which wraps around the waist and goes down the leg and allows a hinge joint at the knee. And so the patient can balance themselves with a walker and be able to walk with just flexing the hip alone. They may be able to ambulate indoors with these KFOs, but it's pretty exhausting. Moving on now, if they get L3 present, they can now straighten the knee with the help of their quad muscles. They have more control, so they can move the leg and may be able to ambulate with AFOs. An AFO is pictured here, which is a brace that stabilizes the ankle and called ankle foot orthosis. The AFO, and these patients are now able to ambulate. So other options for patients with paraplegia is they have functional electric stimulation. Patients who have spinal cord injury lacks the ability to send their impulses from their brain to the muscles. And so the idea of electrical stimulation is you put the electrical signal directly to the nerves that go to the muscles, and so they should still be able to contract and allow for movement. Another option is bionics, which, for example, exoskeleton technology is like a motorized brace. And as you can see here, you have something similar to the KAFO, where it wraps around the waist and then wraps around the legs and thighs. And there's a battery pack which attaches to the back, and it allows for the patient to be able to move with the assistance of a walker. So we're now going into the bowel and the bladder, which is very important for patients who have spinal cord injuries. Then the bowel, they may lead to constipation and fecal impaction, and they would need daily bowel movements. We encourage them having a high fiber diet, and they can use bulking agents or stool softeners, and should avoid irritants like castor oil or mineral oil. These patients, if their constipation is very serious, they may even go on to needing digital impaction, which can either be done by the patient or by a caregiver. In the bladder, intermittent catheterization of the bladder should be started soon after injury and can be taught by nurses. Ideally, we do a post-void volume check with a bedside ultrasound to figure out the best time interval needed to get the patient below 400 to 500 cc's in between each catheterization. Skin integrity is also important because some patients are not able to move freely. And so we encourage frequent weight shifts every 2 hours for lying patients and every 30 minutes for sitting patients. We also encourage to avoid prolonged urine and stool exposure to the skin, and barrier ointments are recommended. So these are pictures of patients of which areas in the body are more exposed to pressure ulcers. So when lying down supine, which is on the back, their occiput, which is behind the head, the shoulders, the elbows, the sacrum, and the heel are most at risk. And when lying down on the side, their ears, their shoulder, the area around the hip, the knees, and the ankles are more at risk. for these ulcers when sitting. The scapula, which is the area behind the shoulder, the sacrum, which is the lower back, the ischium, the buttock, which is the buttocks, the heel, and the ball of the foot are more exposed. And so we encourage adding pillows or putting more softer things around that area in order to avoid
prolonged urine and stool exposure to skin bar. So she said use a barrier.
Oh, not me? Oh, sorry. Okay. So the discharge concerns are really treatment of other medical issues, getting the patient used to the psychological adjustment of having these type of injuries and to prevent any new injuries. With discharge planning, we want to get them used to the adaptations of being at home and to instruct sometimes on sexuality issues. And later on, we focus on return to work and returning to driving. So this is a picture of a football player, Kevin Everett. He was on the football field in 2007, and he sustained a cervical spine injury. At the time, it was rumored that he was only able to move his eyes after his injury. However, with intense rehabilitation, he was able to walk 2 years later on the same field. So these are just some pictures of other people with disabilities. They're doing liberal arts where they're dancing in their wheelchairs. They're doing sports. They're in a rink doing high intensity sports, and even one here throwing javelin in the Olympics. And so the sky is the limit. Thank you. That's the end of my presentation.
Thank you. Thank you so very much, Dr. Bent and Dr. Dawson, for two very, very, very interesting presentations. We can see how passionate you are, both of you, about what you're doing, and it is just fantastic. I know we're running out of time, and I'm going to ask if perhaps we can take 2 questions, 2 comments, questions or comments. And I just want to start off with, and you don't have to answer it right away, perhaps you might take a few others. I can see why it's important to have a multidisciplinary team, but I'm wondering, what's the cost of this?
Wow, that is a very, you hit the nail on the head. It is costly. And I think Dr. Dixon alluded to it yesterday in his presentation. It's costly in terms of personnel and also resources. And even Mona Rehab, Sir John Golden, we don't have an occupational therapist on staff there, but it can be quite costly. The fortunate thing is we do have public hospitals with good physical therapy department. And I think KPH is one of the best, believe it or not. I think KPH has a stroke program there, which is amazing. The University of the West Indies as well, and Spanish Town Hospital. And those are the ones I'm familiar with. They do have good equipment. They could do it a lot more, but there is cost to it. It is costly.
Thank you. Ladies and gentlemen, you have just a couple of minutes. Questions? You could take a couple of questions now.
Hello.
Yes.
Yes, I'm Jennifer Van Horn Paul. I'm a polio survivor. I just wonder if any of what you've just spoken about could be applied to post-polio syndrome.
Thank you for that question. Thank you. Post-polio syndrome, what a lot of people don't know, is 30 years after having been diagnosed with polio, you get continuous weakness. It is not a recurrence of the infection of polio, but it is just the motor neurons that are left are exhausted. What do I mean by that? The polio virus attacks the motor neuron at the level of the spinal cord. And say, for example, it takes out, or first of all, you only need 40% of your motor neuron to walk. 40%, that's how redundant the motor neurons are. And so when you get polio, you would have lost more than 60%, up to 80%. And so you now have 20% or even 5%, depending on your weakness. And that 5%, they're now working for the entire 100%. So those 5% of nerves that are left, they're overworking. And after 30 years, they get exhausted. They literally burn out. And that is what post-polio syndrome is. The difference with polio and what we presented, polio is a lower motor neuron lesion, which means initially the legs are floppy. They're flaccid. They're not spastic. Spastic is more when there's a brain injury or a spinal cord injury. Although the virus attacks the nerve in the spinal cord, it is the nucleus of the peripheral nerve, which is located in the spinal cord, but not the spinal cord itself, which, if you understand what I mean, similar to ALS, which somebody mentioned in the chat. So it's the motor nerve. And so with polio, the nerves stop working because they're damaged because of the polio infection. And after 30 years, they burn out. I remember polio was, I think post-polio syndrome would have seen it already because polio was in the 70s. And so after 30 years is when you start seeing the weakness. Now, there's a difference between when you start having tone, increased tone because of the decreased movement. And so you do get the stiffness, but it's stiffness within a point. It's not spasticity, it's just you're stiff because we're not moving as much, if you understand what I mean. You can benefit from, not from the phenol injection or from the baclofen, or even to CBD, because that's more centrally acting, but you certainly can benefit from therapy, which is range of motion and as much strengthening is available. I hope that answered the question.
Thank you. I see Deodath Sigobin, and I think this will be the last question. Go ahead, please.
Thank you so very much. I'm so excited to hear your presentation. I suffer from a genetic disease called adrenomyeloneuropathy, which causes demyelination in the spinal cord. So I was so excited to hear about this phenol. All attempts with my disease is gene therapy, but first time I'm hearing where you could actually do something about the nerves. So I just would like to express my appreciation for your presentation. Thank you.
You're most welcome. Most welcome. Yes.
So again, I just really want to thank you both for very, very interesting presentations, very informative. I have learned a lot, and I'm sure others would have too. And I think it's just amazing the work that we're seeing being done in this area. It has a lot of hope, I think, gives a lot of hope. So thank you again, and I would now like to hand back over to you, Dr. Goff.
Thank you for the promotion.
You deserve it.
I deserve it. Can I get it without studying? I would love that, you know, because. Okay. I am going to just. I am just going to crave the indulgence just for 2 minutes. I hope Dr. Dawson can respond to this. From I was small, well, they would say I'm always small, but from I was younger, there was this saying among our older folks, non-medical, of course, that you get a stroke on your left and it affects your right, and you get a stroke on your right and it affects your left. And if you get it on the right, it will be more detrimental. Could you just explain that for us?
Love that question. I'm hearing a lot of echo. I really do love that question. So you could probably do it. So, all right. So when you have an injury to the right side of the brain, the right side of the brain controls the left side of the body, right? And the left side of the brain controls the right side of the body. So yes, when you get a stroke on the opposite side of the brain, it controls the opposite side of the body. The stroke on the right side of the brain deals with the part of the brain that deals with insight, the ability to understand your disability. So if you get a stroke on the right side of the brain and you don't understand your disability, you will not be able to understand the rehab process, which is why right-sided brain, which is left-sided weakness, patients, they're a little bit harder to rehab because they don't know or they don't think they have an issue. Similarly, if it's in the frontal lobe, they have a personality issue because that deals with insight and introspection. The patients with the left side of the brain, they're the ones that can't talk, some of them, and they are very depressed because some of them can comprehend, as I mentioned yesterday, so they understand, so they're able to follow instruction in therapy. Whereas the right-sided brain patient, depending on the size of the stroke as well, and we're on the right side, not all right-sided stroke patients lack insight. But if you were to look at all the patients that you know who have stroke with the left side of their body weak, they're very happy. They're very optimistic, and they are very upbeat because they don't see a lot of their deficit as a deficit. Whereas if you see someone with a right-sided stroke, which is the left side of the brain, they're more understanding of their disability. And so, yes, old-time people, I mean, I respect my grandparents, you know. I always tell patients, when your grandmother tell you soak your foot in Epsom salt, she knew what she was talking about. And that's magnesium. Magnesium is now the new thing to cure everything. And so old-fashioned, you know, whatever it is that they taught us, there are some scientific explanation to it. Yes. Dr. Goff?
Be a medical doctor, because I thought that the reason why it's worse when you get it on the right side is because your heart is on the left.
Hey, she's
Interestingly, the brain, upper brain, does not control the heart. That's the brain stem. So it's supratentorial, meaning up here controls the limbs more so than the heart. So you can have a complete stroke where you're brain dead and your heart still works, which you've seen in movies where they donate organs, because the brainstem will keep the heart beating and keep you breathing and keep the bowel moving. And so that's more the brainstem, the cranial nerves. And those are kind of, although they go through the brain, the channels go through the brain, you can still keep your heart beating, and you can still breathe, meaning inspire, expire. Your bowel can still move through, and you can still empty your bladder without having consciousness.
Okay. All right. Thank you very much for that. I am far more knowledgeable now in terms of the left right-sided stroke. So we're going to
Before you do that, you open the gate and I can't ignore this lady, Louise Swinton. She has her hand up, and that's it. Louise? Asked to unmute. Would you please unmute, Louise?
Okay, it's okay. It's Dr. Dawson. I usually take Brittany to Dr. Dawson, but however, she's here with me fully at home. What I encounter with her, even though she sits, she has poor coordination, but can sit in a wheelchair, yes, with support. However, what I notice, if I should put her on, say, for instance, the floor to sit with support, with myself stopping her from falling over, she is unable to fold her legs. Right there in the hip, there is something that is happening right there at her buttocks or in the hip pelvic bone or what. I don't know what happened there, why the leg is unable to fold. So even if you are to stretch those legs out equally, like how we can do it, but yet she can, as I say, she sits in a chair, she can hang over her legs and they look pretty okay, but sitting on her buttocks and folding her legs so it's a big problem. So I wouldn't mind if Dr. Dawson, if I can take her for another visit, because right now don't have an appointment anywhere with her. I basically do what I'm doing at home with her.
One thing with my clinic, Dr. Bent will tell you, we turn back no one. Even if you don't have an appointment, we don't turn you back, especially because I know the cost when you rent a car or a taxi, or just the whole thing of putting a wheelchair in a car is laborious. But tell Brittany hi for me. And there's so much in there, Mrs. Swinton. It might just be truncal control issue. She's in the chair, so she has the support of the back of the chair. It's probably a matter of her trunk control. She doesn't have good trunk control. In addition to that, it might be that the hip is subluxed, which we find very common in children with cerebral palsy. Dr. Bent and I, we just submitted for ethics approval, looking at the subluxation, meaning where the hip falls out the socket in children with cerebral palsy, and look at the sidedness as it relates to which hand the caregiver uses or what position the children sit in. So it could be so many different things, but it sounds like she has weak trunk control. And so when she's in the chair, she's fine because she can balance from the chair, but outside of that, it could be so multifactorial.
I'm talking about the leg. The legs, there's a tightness, even though she doesn't seem tight. But there's a tightness right there. It's like it's the hardest thing to get her fold those legs while she's sitting flat. Even if I support her, there's a very tight, it's tight. She tends up right there. As if something is going wrong right there.
Mrs. Swinton, I look forward to seeing her. You can come on Tuesday at 8 o'clock.
Right. Next week, Tuesday. All right, doctor.
Make sure you come early. Don't come late.
I was so happy to see you on the program.
Wonderful.
Yes, so I'll see you on Tuesday at before 8 o'clock. All right. Thanks.
Thank you. Gloria, over to you now. Thank you.
I'm sure Dr. Dawson, just listening to her, will accommodate you. So we have to close now, and we want to say quickly thanks to all our presenters and our facilitators for this session. And we again apologize for the technical glitch that we had that, have led to us not meeting the usual time deadline. But these were all 4 very important presentations, and we look forward to the next session. Please join us in half an hour. Thank you. Good afternoon again, ladies and gentlemen. Thank you for joining us. I hope you had a good lunch. We did. And I'm sure when I was eating, I thought of you all. And believe me, just that I couldn't share. So we start this afternoon as with two more presentations where we're going to be looking at disability and non-communicable diseases. And we're also going to be looking at community-based rehabilitation regarding children with profound challenges, right? And we're going to be handing over to Mr. Conrad Harris, who is the executive director of the the executive director of the Jamaica Society for the Blind, and he's going to be leading this session. Over to you, Conrad. Is he on?
Hi, good afternoon all, and welcome back to this very, very interesting conference. I'd like to introduce our next speaker. She is Dr. Julian McCoy Davis. And Dr. Davis is a passionate advocate representing issues of Dr. Davis is a passionate advocate representing issues of older adults. She is engaged in teaching, research, community outreach, and policy influence at Mona Aging and Wellness Center, UWI Mona. Her research interests are focused on social and economic issues affecting older adults. She is a board member of the National Council for Senior Citizens, and I know that she is doing double duty this afternoon, so I am hoping that she has had a very healthy lunch. Now,
Good afternoon. All right, so good afternoon, everyone, and thank you very much, Mr. Harris, for that introduction. So this afternoon, as Mr. Harris did indicate, I'm going to be doing double duty. So I'm presenting on disability and non-communicable diseases among community-dwelling older adults in Jamaica, and afterwards I'll look at community-based rehabilitation services. All right, so just to start off, I would like to acknowledge my co-authors, Dr. Duladel Willie Tyndale, Dr. Keon Donaldson Davis, Dr. Tanya Edwards, Dr. Kimberly Ashby Mitchell, Dr. Kenneth James, and Professor Denise Eldemeyer Scherer. And also to recognize our conference host this afternoon, the Regional Disabilities Studies Conference. So just by way of background, non-communicable diseases, when we talk about NCDs or non-communicable diseases, we're talking about conditions that are long-term health conditions that affect persons, such as hypertension, arthritis, and diabetes. And non-communicable diseases are considered to be the #1 cause of preventable and premature death, as well as morbidity in terms of illness and disability worldwide. So we have seen over a number of years that there has been a shift in the epidemiologic profile of countries, in that they have transitioned primarily from communicable diseases to now non-communicable diseases, that is, diseases that are not easily passed on by contact, and diseases that are of a long-term nature. And so non-communicable diseases, or NCDs for short, account for 70% of all death worldwide. Remember, I said earlier, it accounts for premature death. And so many of these deaths are deaths that could have been prevented, and there are also deaths that never needed to occur at the time that they did occur. So, for example, persons are dying much younger than they would have were they not ill. In terms of the cost of these conditions, it accounts for 43% of the global disease burden, and 75% of these deaths occur in low and middle income countries. And so my objective this afternoon is threefold. One, to look at the association between disabilities and non-communicable diseases, to look at the risk factors for non-communicable diseases among older persons with disabilities, and also to be able to provide some recommendations to possibly mitigate against the impact of NCDs among older persons living with disabilities. And so just to look at the methods that were employed in the study. So this study is the 2012 data set of the health and social status of older persons in Jamaica. That was conducted by Mona Aging and Wellness Center. And this study had a sample size of 2,943 community dwelling adults over the age of 60 years old. The study was nationally representative, and it looked at the parishes of Kingston and St. Andrew, St. Thomas, and St. Catherine in Jamaica. In terms of the sample selection, it included a 2-stage cluster sampling method in which individuals were interviewed by experienced data collectors, and there was a standardized questionnaire that was presented to them. Clinical and anthropometric assessments were also done on a randomly selected subsample of 11% of the sample. And so for today's presentation, what we have done is to further disaggregate by looking at the sample of respondents who reported one or more disabilities. And so just for clarification, in terms of the disabilities that we're looking at based on the respondents who indicated that they had either hearing, visual, or physical disabilities. So some results coming out of that study: approximately 38% of the original sample of 2,943 respondents indicated that they had one or more disability. And so visual impairment was in fact a disability with the leading highest prevalence of 82.9% of the respondents. 58.2% of the respondents were female, and the mean age of respondents was 74.4 years. There was a marginal difference in terms of the marital status of respondents, with 31.6% reporting being single and 30.4% married. In terms of the educational status of respondents, 77.3% of the respondents had primary level education as their highest level of education achieved. So that's primary level and below. And 85.6% of the respondents were not currently employed. In terms of functionality, it's very often for persons to assume that as persons grow older, then automatically there are issues as far as their functionality is concerned. However, in this sample of respondents, we did find that the functionality level of respondents was very high. And so there, in terms of their level of dependence, that was relatively low. And so even among respondents, the respondents who were persons with disabilities, the highest frequency in terms of persons who depended on others for assistance was that they required assistance with bathing. And that was a mere 9.7% of the respondents. And you see for the other areas of dependence in terms of dressing, toileting, transferring, continence, and feeding, those were minimal. In terms of chronic disease prevalence by age, what we found is that the NCD prevalence varied significantly by age for hypertension, arthritis, and stroke. And so in terms of hypertension and stroke, this was highest among the 70 to 79 age group. And so these persons are typically recognized as the middle old. And so just for clarity, we have what we call the young old, that is persons 60 to 69 years, the middle old, that's those 70 to 79 years, and the old or the oldest old, which will be persons 80 years and over. And so what we found is that persons with arthritis the lowest levels of arthritis was reported among persons who were between 60 and 69 years old. That's the young old. And so there was basically no other statistically significant differences in terms of the other NCDs that was observed. In terms of chronic disease prevalence by gender, significantly higher prevalence estimates were recognized by gender. In terms of females reporting higher levels of hypertension, coronary heart disease, diabetes, and arthritis, while males reported higher levels of cancer. When we look at morbidity status, we're basically looking at the health condition or the sickness level of respondents. And so what we're looking at here is the number of chronic diseases reported among persons with the different types of disabilities. And what we found is that over 50% of respondents, irrespective of disability type, did in fact report having 2 or more chronic diseases. And so when we speak of 2 or more chronic diseases, we now start speaking of multimorbidity. And so this was basically significantly more common among respondents with physical disability in comparison to the other types of disabilities. In terms of morbidity status by age and disability types, the highest prevalence of multimorbidities, that is having 2 or more morbidities, was reported among the old, that is persons who were over the age of 80, and those who had physical disabilities. Females also bore a higher level of multimorbidity, having 2 or more morbidity chronic conditions in comparison to the male respondent, irrespective of the type of disabilities. Now, when we look at the 4 NCD modifiable risk factors. Now, these are risk factors that are known in the literature to be factors that persons can change, so they can modify in order to be able to contain or to prevent the likelihood of having any of these health conditions. And so the 4 risk factors that are commonly looked at are alcohol consumption, smoking, physical activities, and BMI. And so we found that 36% of the respondents had had an alcoholic drink over the past 12 months, while 8.7% of the respondents were current smokers. In terms of fitness activities, 60% of the respondents indicated that they were engaged in fitness activities. As far as BMI, which is body mass index, is concerned, 43.5% of the respondents had normal BMI. However, 22.9% were obese, right? And so in terms of BMI, as it relates to BMI and age, we found that obesity levels was highest among respondents who were 70 to 79 years old. That is 33.3% of the respondents indicated had obese levels, as well as those who were 80 years and older. Looking at BMI, gender, and fitness, what we found is that there was significant variation by gender. For example, 32.9% of females in comparison to 9.1% males were obese, while 35.5% females had normal weight in comparison to 54.5% males. In terms of the reasons that respondents provided why they were not able to engage in physical activities, the three common reasons were pain, 28%, illness, 26.4%, and physical limitations, 25.1%. So in terms of the number of health professionals seen in the last 12 months, what we found is that more than 80% of the respondents had seen a health professional in the last 12 months, which was very good for this cohort of respondents. We noted higher healthcare utilization was reported among females, 60.9% in comparison to 39.1% for males. And approximately 44% of respondents had seen between 3 and 4 health professionals in the last year. There was no statistically significant association between the number of health professionals seen and gender. There was, however, statistical significance in terms of the number of health professionals seen and the age of the respondents. So we found, for example, that respondents who were between ages 70 and 79, that is the middle old, reported the highest number of visits to a health professional over the last 12 months. And so between 3 and 4 visits, 44% indicated that they had between 3 and 4 visits. Now, the primary reasons why respondents sought professional health services were for routine checkup, that's by 73.3% of the respondents, as well as for the management of their chronic disease condition, 38.7%. Another interesting finding among the respondents is that 57.7% of the respondents did express concerns about their challenges for them to be able to afford the medication. And so consequently, they were not able to purchase their medications all the time. So let's just go into some discussions about the findings that we just saw. So based on the findings coming out of this study, what we find is that chronic disease prevalence was on average 6.2 percentage points higher among persons with disabilities in comparison to the general population. We also noted that hypertension prevalence was 2 times higher in comparison to that which was reported for diabetes. In terms of the healthcare use over the past 12 months, we found that 50% of the respondents had seen a health professional at least 3 to 4 times over the last 12 months. And that healthcare access is very critical for older persons with disabilities. The findings also corroborate studies that have been conducted, for example, by Craig et al. In 2020 and Mitchell Ferron et al. 2014. So we note that there's a higher prevalence of multimorbidity, that is having 2 or more chronic conditions among females and the oldest old, in comparison to males and the youngest old. We also note higher levels of healthcare use among respondents with 2 or more chronic conditions. So having multimorbidity, having 2 or more chronic condition also implies that there is higher healthcare usage, as indicated earlier, but also greater levels of healthcare spending. There are a number of challenges, however, that are noted in terms of NCD management. And this includes that there is limited public awareness about drug subsidy. So for example, in Jamaica, there is the drug subsidy program provided by the National Health Fund. And within the National Health Fund, it provides a service specifically for older persons called the Jamaica Drugs for the Elderly Program, JDEP for short. And so it is interesting because under the JDEP program, these chronic conditions that we have been discussing are all covered. And in this case, it provides medication on a monthly basis, a monthly dose of medication for 40 Jamaican dollars, which is much less than $1 US, maybe at about 50 cents US. And so it is interesting to note that so many persons were complaining about their inability to be able to afford medication. It means that they are not aware of this provision by government. It also means that if they're not able to afford and to purchase these medication, they're also not being compliant with their medication requirement. We also note in terms of the modifiable risk factors that there is more that can be done, that persons can do, especially persons with disabilities, to change some of the risk factors that they're exposed to and minimize that. Poor nutrition is also something of concern, and naturally low levels of health literacy in terms of persons not being aware about available services and what it is that they should do. Now, just referring to the Disability Act, which was recently approved in Jamaica earlier this year, the 2014 Disability Act says that a person with a disability shall be provided with the health services required because of that disability, including screening, early detection, treatment, rehabilitation, identification, and intervention as appropriate, and services designed to prevent or minimize any further disability. And so, having seen that and seen some of the findings coming out of this study, what we're recognizing is that there is need for key stakeholder engagement and also a level of responsibility to be able to mitigate against the worsening development of other disabilities or chronic conditions that would exacerbate an existing condition. Something that
Dr. Davis, you have 3 minutes to go.
Okay. So something of note is the fact that disabilities can in fact lead to chronic conditions, and chronic condition vice versa can in fact contribute to persons developing disabilities. So some key recommendations coming out of this study. One is that we need to also have prevention and control strategies for persons with disabilities. So screening and health literacy information resources. We also need to develop activities that promote physical engagement for persons with disabilities. And I know some mention was made of some of this yesterday. In terms of registration processes for persons with disability to social assistance program, that is something that is important and that can easily be done. There's also interdisciplinary training from community health aid as well as other persons that can facilitate. Given, for example, that we're in an educational setting, there are a number of departments, for example, that have students who need placement. And so these provide a perfect opportunity for students, persons in training to engage. And so in conclusion, I just want to share that given the high cost of care for non-communicable diseases and the kind of economic impact and strain that it places on our country, is very important that we put different mechanisms in place to mitigate against the development of other chronic conditions among this population, and also to be able to prevent the development of other disabilities using a multi-sectoral approach. Thank you so very much for listening. And here are my references.
Okay, we want to thank Dr. Davis for that very, very interesting, informative presentation. You know, a number of issues came out of that in terms of looking at, you know, fitness, looking at how we deal with the issue of ensuring that older persons have access to, you know, regular care, and want to open the floor for any questions or any comments that persons might have relating to this or these issues. Any questions or comments for Dr. Davis on the matter discussed?
Good afternoon. I am Jennifer Van Horn Paul, and just want to mention that some of the pharmacies do not support the JDEP program. Many times you go, they just say no. One pharmacist told me that because the government doesn't refund them as quickly as they should, but they don't support the program, some of them.
Okay, you have a response to that, Dr. Davis? Anything you want to say in relation to that?
All right, so thank you very much for that comment, Mrs. Van Horn Paul. Just to say that I'm aware of that concern in terms of some of the pharmacies not coming fully on board. However, what I would suggest is, especially for this population of persons, is that if at the community level, there can be some kind of networking to be able to identify which pharmacies are on board. And so to be able to relay that information to the members so that they're able to engage with those pharmacies directly. There's also a need for ongoing advocacy at a higher level as well, to be able to encourage the government through their channels to get more pharmacies on board. So I'm in agreement with your comment. Thank you.
Thanks. Go ahead.
May I please, Conrad?
Yes. Go ahead, Sarah.
Thank you very much, Dr. Davis, for that presentation. The question on employment, the unemployment rate is extremely high, in my opinion.
86%.
Yeah, that's too high. Were you able to find out really what is the main reason for this high unemployment rate? Is it a lack of training? Has it got to do with the educational standard? There seem to be multiple reasons why. Were you able to identify some of those reasons why it is so high? Because that's not saying very well for our community of persons with disabilities.
All right, thank you so very much for your question, Mrs. Newland Martin. All right, so first off, I must indicate that that we are speaking of the population of persons 60 years and over.
Right.
And so it is not necessarily strange for us to see high levels of unemployment. And maybe unemployment in context should really mean that they're not currently working, they're not employed now. I can interrogate the data some more to see if this differed significantly in comparison to the rest of the general population, but it may not necessarily be so given that many persons retire at a certain age. So it's not necessarily something that is strange, but I will check the data to get some more clarity on that.
All right, thank you.
But in truth and in fact, the unemployment rate among persons with disabilities is very low. And it's something that we need to see how we can help to advocate on their behalf.
That's correct. Mm-hmm. Thank you.
Other questions? All right, for me, One of the issues I would probably want to see you elaborate on was the fact that I think you indicated that over 50% of persons had 2 or more chronic diseases. And, I just wondered, what that really meant for, the quality of life of, the population that you're looking at.
All right, thanks for that question, Mr. Harris. So having 2 or more chronic condition, as I mentioned earlier, is called multimorbidity. And I also indicated, for example, that having a disability can contribute to persons developing chronic conditions. Meaning if somebody has, for example, a physical disability, they're not able to move about, and there are some risk factors that they are exposed to, for example, having a sedentary lifestyle, sitting for long hours, eating the wrong things, and so this person becomes obese, then it also increases the likelihood, for example, of them developing NCDs. I think it's really a double whammy for persons having a disability already, and then on top of that, having NCDs that, for example, because of their health condition, can increase. And so you asked in terms of the quality of life of persons that have more than one disabilities. If the condition isn't managed well, it means, for example, and for example, their socioeconomic factors, for example, that may also impact, because if persons have the economic means and the other wherewithal to survive and to manage the condition, then their quality of life may be better. But based on the literature, we also know that many persons, for example, with disabilities also have poor health outcomes, also have low socioeconomic status. And so that, for example, can contribute to them having a poorer quality of life if they have more than one disabilities.
Well, in contrast to that, though, you did, if I heard correctly, the level of, I think, fitness, if I could put that, what seemed to have been high.
It was high, that's correct.
Yeah, how do you relate those two things?
Well, for the respondents, they indicate 60% did indicate that they were physically active, which was very good. Yes. However, we note that some of them, in terms of those, the other 40%, some of the reasons that they provided that they were not able to engage in physical activity would have been based on the level of pain that they were experiencing or their physical limitations, and so they didn't know how to do what. And so it means from a health literacy perspective, it means that there is more that can be done and should be done to increase the awareness of persons so that they're able to understand, irrespective of your limitation, that you still can be engaged in physical activities. You still can be doing other things that minimizes your risk factor for developing other chronic condition. But as you did indicate, their level of physical activity was very commendable.
All right, so any other questions for Dr. Davis?
This is Bether Parry. So actually where Mr. Harris left out in terms of, the 40% that are not exercising, they have reasons in terms of pain, illness, and so forth. And you're saying that there are avenues to explore in which, this could possibly change. I'm just wondering if any such avenues presented right now in the public way in Jamaica to increase literacy among those persons, and not only among them, but among the younger population, because I suspect these, I believe these are lifestyle choices that even lead to the amount of NCDs among the older population. I'm wondering if there is any sort of program that promotes this sort of literacy in Jamaica. And by the way, awesome presentation. I didn't say it earlier, but I'm saying it now. Thanks, Julianne.
Okay, thank you so much, Dr. Parry. All right, so thank you for your question also. just to indicate that we do have different programs in Jamaica, primarily through the Ministry of Health, that are geared towards increasing public awareness about NCDs and their impact. One of the challenges, however, is that sometimes people don't recognize these conditions in middle age, mid-age, or younger age, for example, as much as they see it in the older persons. And so they may not easily relate to it. However, we have, for example, Jamaica Moves, which I know is also in other Caribbean countries, that we seek to engage our population as much as possible in physical activity and doing other things. There are other educational and public awareness programs that are on the way, provided by the Ministry of Education, as well as some corporate entities have gone ahead and done their own physical activities as well. However, there is need for sustained on an ongoing basis for that kind of education, and for persons to be able to make the connection between what they do in their younger lives and how it impacts them as they grow older. Just to say that at the center here at Mona Aging and Wellness Center, we're in the process of looking at a study that seeks to examine just that, how it is that persons in their middle age, for example, 40s, 30s, would develop conditions that can impact them in the long term. But there is definitely need for other similar programs and public awareness entities to be developed. And I think the results that we'll get from that study will definitely provide some kind of impetus going forward. Thanks.
All right, thanks, Dr. Davis. Are there any other hands that are raised that haven't spoken, that need to say something? If not, I will then permit Dr. Davis, permit for you to move on to your other presentation. And of course, you're going to the other spectrum now, looking at it takes a village, looking at community-based rehabilitation, and how viable it is in terms of complementing the raising of children with profound disabilities. So over to you.
All right, thank you so much. All right, so the second presentation is It Takes a Village, and I'm looking at community-based rehabilitation as a viable complement to raising children with profound disabilities at home. Okay. 1 minute, seem to have a slight technical. Okay, so in terms of acknowledgement, just want to acknowledge the co-author, the lead author for this paper, Opal Bailey, who is unavoidably absent. And of course, I did recognize our conference host earlier. So in terms of background to this study, the concern really is coming from looking at children who have profound disabilities. And so the challenge exists that for many persons, for many families, raising of these children is something that is challenging. However, there is a cultural expectation that these children should be placed in institutional care. And so what we're doing in this study is to explore the phenomena that influences some parents to defy that cultural expectation and to actually raise these children at home. So approximately 29,000 children, according to our 2011 population and housing census, did in fact report that they had at least one disability. Disability increases children's vulnerability. And so they are limited in terms of what it is that they can do as a result of their disability for the most part, in terms of their socioeconomic outcomes. So their ability, for example, to access health, education, their employment prospects in the future are often affected by their disabilities. It can also increase the likelihood of them falling into poverty. And so what is needed is that ongoing efforts are needed to be able to support the process to ensure that children are not left behind. So persons with disabilities also have poorer health outcomes in comparison to persons who do not have disabilities. There's also stigma and discrimination and marginalization, which may result, and so persons are often considered to be on the margins, on the fringes of societies. And so many of them are denied their access and right to education and appropriate educational support. So in a 2011 audit conducted by Morris, he looked at the inclusion of persons with disabilities into 100 educational institutions in Jamaica, that is primary and high schools. And that revealed a number of weaknesses. So although as a country, we are of the view that everyone, irrespective of your condition, everyone has a basic right to education. And so, although we often accept these persons, there are a number of barriers, for example, in our educational institution that limits the access and integration of these children into the educational institutions. And so, for example, most schools did not have ramp access. In terms of wheelchair accessible bathrooms, the classrooms, the adaptive technologies, for example, for persons to be able to read, as well as for them to do examinations, were very limited. So our objective today is to explore the factors that influence these parents to care for these children, and also to be able to identify community-based rehabilitation services that can complement the rearing of these children at home. In terms of the methods that were employed in this study was a phenomenological study, a qualitative study, and it was conducted with 11 parents who are the primary caregivers of children with profound disabilities. The participants were selected from the School for Therapy, Education and Parenting, otherwise called the STEP Center, and it was done using criterion sampling. A DEX review of 5 community-based rehabilitation services were also examined. Semi-structured interviews were conducted with the parents to collect the data, and the data was analyzed using content analysis to derive key themes, and the CBR services were examined using the World Health Organization CBR matrix. In terms of the theoretical framework that was used in the study, 2 theoretical frameworks were explored. One is the family system theory, which basically posits that families are a system that, persons are interconnected. And so we cannot look at an individual in their own merit. We have to see the family as a whole. So no one can be understood in isolation. We have to see everything together. The other one is family resilience theory, which posits that the strength that is found in the families is very strong, that enables them to be able to withstand and to cope with very traumatic life situations, to bounce back and basically move on. So you may hear of terms about thriving and resilience, among others. So some findings from this study include the fact that we interviewed 11 participants, and these 11 participants were parent to 10 children. So it meant that we did in fact include a mother and a father as one of the persons, 2 of the participants in the study. 7 of the participants were married and 3 were single. 4 respondents did indicate that they had at least 2 other children, and 2 of those children were teenagers, while 2 were under the age of 5. Now, 10 of these were children, so all the children in the study were diagnosed with multiple physical disabilities. In terms of the situation of the parents primarily had medium to low socioeconomic status, and their educational levels were also medium to low. They recognized that emotional, physical, and financial support were very critical in their provision of care. And on average, they identified 100,000 Jamaican dollars, which is approximately 648 US dollars, to be the average cost of care for their children on a monthly basis. Now, caring for children with profound disabilities for them was something that was very stressful, and many of them did, in fact, 8 of them did in fact have family support. However, 3 did not. And these respondents who did not have family support indicated that their families strongly opposed them, providing care for their children. And one of the arguments for this was that providing care for children for the child with the disability would in fact impede the parents' career pursuit. And so in that case, support was provided by other non-biological entities, such as the church community, a political representative, or the school principals. There were also services that were required, but many of the parents indicated that they could not afford the services, such as physical and speech therapy that was often recommended. So for the 3 mothers who indicated that they had to cope without family support, their comments directly are. So we're gonna call them by different names. So Violet, for example, says, "He, that is the member of parliament, treats me better than my flesh and blood. If I never for him, I would have never get a small business loan, and I now have a community wholesale." So she was able to, with the help of her member of parliament, to develop a business in which she's able to provide care for her child. Another, who will be called Barbara, says, "I don't have any family support. I work hard to care for my son. I'm doing an online culinary course to obtain a degree." And the other, who is Shauna, says, "I get very overwhelmed when I think of all the expense that is required to care for her. And I know my pay can't meet my financial obligations, but my boss is like a mother to me. She ensures that I get all the government benefits that are in place to care for Sasha." And so when we think about some of the factors that came out of the study, for example, the themes, we recognize love in terms of the connectedness of the parents to the child. We also recognize that guilt was an important factor, in that the parents felt that they would feel guilty if they were to abandon the child, to hand the child over to institutional care. And so they rathered to provide that care, which led to the whole element of parental role and responsibility, recognizing that as a parent, it is your role, it is my role to provide care for this child, irrespective of the condition. Practical support was something that came out very strongly, that definitely was needed to provide care for the children, and that was provided irrespective of biological or kin, that is, persons who are not family, but are like family to persons. There's also innate personality trait in terms of the resilience and ability of the parents to bounce back irrespective of their situation and to move on. So now let's just turn our attention to the community-based rehabilitation services. And CBR, in short, was introduced in the 1980s. It's an inclusive approach that looks at rehabilitation and provision of equal opportunities and integration of persons with disabilities. The key stakeholders in this are persons with disabilities themselves, as is often said, nothing for us without us, families, and communities. And so we're going to look at 5 such services. The World Health Organization has developed a CBR matrix in which they look at 5 critical components of health, education, livelihood, social, and empowerment. And so we're going to, in looking at the School of Therapy for Education and Parenting Center, this is an independent school, which is for students between the ages of 2 to 18 years old with severe, profound disabilities. And so the school offers services in a number of areas, including therapy, and they also provide advocacy and training for both staff and parents, as well as other professionals, to increase their level of awareness and knowledge of how to provide care for persons with profound disabilities. There is one major challenge, however, with this institution, in that there is no transition program or school system in which the students would matriculate to after they leave the STEP center. So in our normal school system, for example, primary and secondary level education, you typically transition into, for example, vocational or tertiary level education. However, this is not something that is readily available. The other one is the Sir John Golding Rehabilitation Center, and I know we spent a great deal of time looking at that yesterday. This facility is an integrated multi-service facility that has both a pediatric ward as well as a general 64-bed hospital. And there are a number of services that is provided. I know Mrs. Bola Hines presented on that yesterday, so I'm not going to go into that. But also of note is the fact that they do provide livelihood services to persons with disabilities, and as well as on-the-job training. Another entity is the Community-Based Rehabilitation of Jamaica, or CBRJ. And this targets children and adolescents with disabilities as well as their parents. It has 4 different locations, and it looks at quite a number of disabilities area. They also conduct weekly home visits using community rehab workers to basically assess the targets that were agreed upon and to develop new targets for persons living with disabilities. They also have educational services which they provide for children in the preschool years to basically equip them and prepare them for transitioning into the formal school system. There is also Abilities Foundation, which is an entity that collaborates with a number of other agencies to provide vocational and entrepreneurial and support training services. There is 3Ds Project that provides services to persons with disabilities. It has main areas of focus, but it's also looking at education, economic, and social aspects of rehabilitation. And it basically promotes an inclusive environment for persons with disabilities. So when we put all of that together, we recognize in terms of the CBR matrix that there is, for example, one entity that would have met all the criteria. But we do understand that given resource constraint, that no one entity is always able to provide anything, everything that is required. And so we recognize, for example, that the service that was least provided among the agency was health. However, this is something that is very critical in CBR, the provision of community-based rehabilitation.
Dr. Davis, 3 minutes.
Thank you.
Okay.
So in terms of our discussion, we know that Jamaica is a signatory to the UN Convention on the Rights of Persons with Disabilities, and that the Disability Act, for example, promotes that persons with disabilities should have access to training, education, healthcare, and accessible facilities, right? And so this, for example, the UN Convention, as well as our Disability Act, for example, promotes the need for further examination of the provision of CBR services. Given that there are social determinants of health, as stated before, that can affect persons with disabilities and limit their access in terms of health, is very important for other collaborative activities to be in place to be able to support families of persons with disabilities who choose to provide care for persons at home. And so the provision of services at the community-based level is something that is very critical, that would in fact limit their need, the need for high expenses. So for example, in the study that we looked at, most of the respondents did not reside in the parish in which the step service was provided, they had to commute. Those are some of the costs that could be averted. And so in Jamaica, there are 39 special educational institutions. Most of these are concentrated in our urban centers, with at least 3 parishes having no special ed services. And so limited educational services, for example, pose a challenge to our mantra of no child left behind. It leads the parents, for example, to make decisions, difficult decisions that can in fact pose problems for them. In terms of family resilience theory, as well as family system theory, we did see evidence of both of these actively in the study, which would have been the reasons why families would have chosen to care for their children at home. And so using the CBR matrix, we're able to make some suggestions. Although we did in fact recognize that the sample size was modest, there are data saturation was in fact achieved, and there are a number of suggestions that can be derived. So for example, educational services for children could be aligned with the traditional educational system in Jamaica. And I know we spoke at length about this yesterday, about including special ed into our general curriculum in Jamaica. And that would mean a greater ease for persons with disabilities, children with disabilities, to be integrated into the general educational system. We also need to develop strategic partnerships with healthcare providers and other service to be able to, for example, provide respite care for parents who are providing care for their children, as well as to explore other options. So they spoke about the challenge in terms of costs for physiotherapy and speech therapy that can be provided like on an intern basis at the community level. There's also need for self-help disability organizations, that we need to see more of these at the community level and for them to be actively engaged in providing services and advocacy for persons with disability. There's a greater need for awareness about the provision and the availability of social assistance programs that can alleviate some of the problems that persons, the parents of children with profound disability experience, as well as the need to facilitate parental empowerment and income generating activities. So in conclusion, I just want to indicate that limited access to supportive services can increase the likelihood of social exclusion and isolation. And so there is need for strategic initiatives to engage different stakeholders, multiple stakeholders, in order to be able to provide services to persons with profound disabilities at the community level to mitigate the need for them to go external and to incur unnecessary expenses. Thank you.
Are you hearing me?
Yes. Yes, I am. Thank you. Mr. Harris, I'm not hearing you now.
Each time I'm on mute, I am muted. I'm not sure what is happening, but I think I am good now. And I was saying that, you know, it's amazing the amount of information that you obtain from, you know, doing these studies. And, you know, I'm looking at this one, and, you know, you used 11 participants, and it, you know, just a wealth of information coming out there. And I have a number of questions, but I think I did see at least 2 hands. I think so. There was somebody, and then Sarah. So I don't remember the person who raised their hand first. If you can identify yourself, unmute and go ahead. And then I think Sarah is second.
Thank you. This is Dr. Kamabach. Thank you so much, Dr. Davis, for a very informative presentation. I have a quick question on what counts as a special education institution. I know your source was the Ministry of Education, and I saw they had Portland listed as not having a special education institution, but there is a Port Antonio unit for the deaf there. So there is special education, but for deaf students. So I was wondering if they were referring specifically to mobility handicaps, etc., when they refer to special education.
Well, I can in fact refer to, it's the Ministry of Ministry of Education's 2019 publication about the actual, it's the directory of educational institutions. And so I basically refer to what it is that they had listed. And I do understand your point in terms of there is a facility in Portland. I'm not sure what would be the reason why it was not listed as one. But the directory did in fact indicate that 3 parishes did not have that service. So I stand corrected if it is that it's otherwise. Thanks.
I'll check the ministry. Thanks.
Yes.
All right, so I think Sarah had a question, and then I think there are about 4 other persons now. So Sarah, go ahead.
I didn't have a question. I just wanted to express my appreciation for this amazing presentation and to say thanks.
Thank you, Mrs. Newland Martin. Thank you.
All right, so I'm not able to quickly identify the persons who have raised their hands, but let's say, well, I say open your mic and answer. If there's a conflict, I will intervene.
I see my hand up. I don't even know why it's up there. I was trying to get it up, but I have something very important to say. First, I thank you for this program. I've been fixed from yesterday with it. However, I'm a retired teacher, but I have a situation that I dealt with because I have a physical challenge child. It seems as if the administration got this little girl who hardly could help herself, and they passed her on to my class. So it was a joy helping that little girl. I was proud. So I asked them, why do they give me this child? They said, because you have a child like her, or something similar. So I think you do well with the girl in your class. Yes, I did. But I had to lift that child up and down the stairs. She couldn't carry herself up and down the stairs at that early age. She was a grade 1 child. And I had to lift the child bodily up on my little shoulder, up on my shoulder, and I was just 5 feet 1 inch tall. And up and down, every move the child wanted to make, I have to do that until little by little, I held her hand and she took her little steps up and down until I was proud to see her in grade 2, how well she was managing herself. The mother was very proud of what was happening. However, even her little feet, they could not touch the ground in the chair she was sitting. So I had to improvise something, a log or something. I don't remember what I used, so that she could put her feet on it and, handle herself well in the class. Teachers came in, they saw her feet rest on the object, and they were asking me, why was that there? So I was telling her those feet were not supposed to be hanging. They need to be supported. And if I didn't get some of the education I got with my child, I wouldn't know how to apply myself to that child that so efficiently. Therefore, the teachers, if we are going to allow these children to be in the regular system, the teachers have to be educated, and some little things we might take for granted, they might not know. So the teachers will have to be educated how to deal with these children when they come in the system.
Thanks for that, and for sharing your creativity in dealing with this situation. I'm sure that some of our other persons who are listening are learning from those comments.
Okay, you're welcome.
Another.
Hello, good afternoon.
Yes. Yes, Editor Van asked a question.
Okay, good afternoon. I'm not really asking a question. I'm rather making a suggestion.
Sure, go ahead.
It's long term. It may be long term, but as an early childhood teacher in training, I do find that the level of activity to play, which is an integral role in children learning, is limited. Most of us from different socioeconomical background are not able to have structures in place for our children to adequately play, and neither is that possible within the school system or within the general social system. There are hardly any public playgrounds, let alone accessible playgrounds. So I'm not sure if this would fall within the Ministry of Education or I'm not sure which ministry it would fall under, but inclusive playgrounds should be made mandatory, because this is a part of how they learn, this is a part of how they socialize. You cannot have them integrating and socializing if they're not having access to play. Play is imperative, not just physically, but emotionally and otherwise. So this is something that really needs to be part of in the public space. You may find this in some private institutions, which the middle income to low persons may not be able to afford. So this is something that also needs to be looked at. I'm not sure as for the Caribbean, but I know that in Jamaica, it is next to none. There is no accessibility for play, and there's no representation enough, whether within media, social media. If we could have some access to that, it would be awesome.
Thanks. So, Dr. Davis, you want to add anything to that, or make any comment on those sentiments?
Okay, so thank you very much for your comments. I want to recognize, with the person who spoke earlier, I think it was Miss Swinton, about her creativity and what it is that she had to do within the school system. And definitely it really just highlights what was the results from the study from Senator Morris in terms of the level of preparedness of our educational system to integrate children with disabilities into the school system. So I agree with you that there's definitely need for more to be done. And also for the last person who asked the question about the accessible playgrounds, that also is something that is very important. So when we think about, for example, our Disability Act, which was recently adopted, and how it is that we now need to implement going forward, we recognize that we have to be operating at different levels to be able to integrate and to ensure that our children with profound disabilities, children with disabilities in general, are able to participate and engage in society as any other child would.
All right, thanks. I think there was another hand, and I think I just saw two new persons, but I think, yeah, go ahead. I think I hear the voice. Go ahead.
Thanks, Julian, for amazing presentation. I really love the work that you're doing. And well, I really wish there were more than two presentations, because I just can't get enough. There is a comment that's coming to mind when something that came to mind when I heard your work. So I'm not sure if you said it and if I missed it, but what were the ages of the children? And the reason I'm asking is because I did some work on care with regards to older persons with disabilities in the context of Trinidad. I know it's a different context, but this is what I found. Not all relatives were willing to home care for older persons with disabilities, all linked back to the ethics of care framework, where you have the right to care, but you also have the right to reject care as well, right? And so I'm just wondering, what ages were these children? And I think it's an idea for future work as well, in terms of at what age would these views of the parents change? Because I'm hearing the word guilt and love and so forth, and I'm wondering if that is going to transfer in their responses as these children grew older and as they grew into adulthood as well. So that's my, it's not really a question. I don't know if it's a question, but yeah, that's my 2 pence. Thank you.
All right, great. Thanks a lot, Dr. Parry. So in terms of the children of the parents in the study, the children were under the age of 18 based on the fact that they were in the STEP center. So that center only accommodates children up to age 18. But the children were primarily younger age. We did in fact recognize that some of the parents had other children. So they were caring for multiple children at the same time while caring for that child with special needs.
All right. There were, I think I saw 3 hands raised. So can I hear, sorry, yeah, those of you who have your hands raised, can you just say your name for me? Because I think it will be the last set of questions.
All right, is that over to me now, Conrad?
Sorry?
All right, just making sure you can hear me. All right, this is Robert Blake.
Robert Blake, hold on, Robert.
Medical. I have a child
all right, go ahead.
who is non-verbal, right? Watch this. And I had to take the child to doctor as a father. But because of the whole COVID, now what's happening? Unfortunately, they did not want me as the parent to be there with the child, even when the child was admitted, and the child is non-verbal. Now, does the Disability Bill Act that we have, does it speak to that regarding the health system and help me? How can I sue the doctor or the system for not making the necessary, putting in certain things in place to help me to facilitate our children who are sometimes nonverbal and not able to communicate? That's one question. Number 2, I'm still a parent that have a nonverbal child, right? What provision is there in the health system for me as a single parent, can't afford any money at all, not even able to work because of the special needs child that I have? What is out there for me that I can look forward to, whether it's in the health system, whether it's support group or whatever? What do we do as parents of special need children? Those are my 2 questions, please. Thank you.
All right, thanks, Robert.
All right, thank you very much, Mr. Blake. I'm going to revert your first question to Senator Morris, and I'll answer your second question. So in terms of social assistance programs that are available, I would strongly recommend, I don't know if you're already a member of the Jamaica Council for Persons with Disabilities, but you could contact them, register with them to be able to access available services. And I do know that from time to time, there are other services or benefits that they do not always offer, but that becomes available to them on an ongoing basis. In terms of other services, there is assistance that you can also get through the Ministry of Labor and Social Security, through either from our Poor Relief Department or Public Assistance Department, or there's also the Program of Advancement through Health and Education. So I strongly recommend that you direct your attention through Jamaica Council for Persons with Disabilities and also through the Ministry of Labor and Social Security for assistance in that regard. But something that wasn't stated here, but is in the bigger paper, the paper that we would have submitted, is the need for ongoing discourse as it relates to the health needs of persons with disabilities, as well as, for example, I know Senator Morris made mention of that in a previous paper about the inclusion of special health conditions, for example, in our National Health Fund system in terms of our drug subsidy program. So there's need for ongoing advocacy in that regard to be able to get some of the medications that are needed for persons with disabilities to be included, more of them to be included into the National Health Fund program, as well as to agitate for other service provisions for persons.
All right, thanks. And I think, as I said, I think there are 2 hands that I had seen. So my second to last question, you can go ahead, whichever of you.
This was Dr. Cumberbatch. I had raised my hand again to just
Yes,
say
I
to the
did see that,
teacher,
and then you took it though. Oh, okay, go ahead.
yeah,
Mr.
that
Mr. Harris,
it is
Mr.
possible.
Harris, one
Yes.
moment, Mr. Harris.
Yes.
Because I have to respond to a question and that they had
apologies,
referred
yes.
to me.
To you,
And
yes,
then
go ahead.
after Dr. Cumberbatch's question, then we have to close out because we are running against time. Robert spoke to that particular experience, and in this instance, he would be acting in the capacity as a parent or a caregiver of the child, which the legislation makes provision for. Now, if it is that he's aggrieved with the fact that the medical facility never allowed him to be with the child, he should have or should have had a discussion with the medical facility to let them know his position. And if there wasn't amicable solution of the matter and if he's so aggrieved, then the process of lodging a complaint to the Jamaica Council for Persons with Disabilities as stipulated by the legislation would trip in, and then the JCPD would be mandated by law to investigate. And if it is that the JCPD conducts its investigation and they believe that the matter should go to alternate dispute resolution, they can make that reference. But it has to be with the agreement of the complainant. And then if that isn't an option, the matter can be referred to the Disability Rights Tribunal. But there has to be a process that is followed, and the Disability Rights Tribunal will come in at the back end of the investigation and referral from the JCPD. But that is how the process would work in terms of what the legislation anticipates. So you can't just go and take an action against the medical facility just like that. You have to, the process requires some form of mediation, intervention, discussion, investigation before it is referred to the Disability Rights Tribunal. And that is how the legal process works, even outside of the Disabilities Act. So, you know, that is how the advice I can give in accordance to the legislation. So we take the question
thanks,
from
Senator, and then we can take
Dr. Cumberbatch.
All right,
Yeah,
thank
Dr.
you.
Cumberbatch, and then we sign off on that.
Okay, it's not a question, it's just quick information. The Ministry of Education actually employs shadows for situations where you need someone to carry, for example, a cerebral palsy child to the bathroom, etc., or just move the child from one room to the next. So you can ask the principal to contact your education officer and liaise with special education unit to have a shadow assigned to your school. And it could even be the child's parent who can get the job.
All right, thanks for that, Dr. Cumberbatch, and thanks to you all for your participation, and to Dr. Davis for those two very, very interesting presentations. I'm sure there are more questions, but time doesn't permit, so I'm going to hand back over to the chair, and so that we can continue.
For conducting that session so well. A very interesting session, and the presentation, one person had to double up, and of course she did it very well. and didn't sound tired of the end of it, because it sounds like a topic that not only she knows very well, but is very interested in. Thank you very much. And now we move to our next session. And this session will be moderated, who will tell you all about the session is Miss Tamisha Powell, who is an attorney at law and also very knowledgeable on disability issues. Miss Powell.
Hi, afternoon. Thank you so much, Chair. I thoroughly enjoyed Dr. McCoy Davis's presentation as well, just to chime in with regards to the comments that have already been expressed. So we're now going to go into our session that will be led first by Dr. Tanya Edwards. And Dr. Edwards' topic will be facilitating COVID-19 vaccine administration to persons with disabilities, best practices based on service delivery at Mona Aging and Wellness Center, vaccination site at the University of the West Indies, Mona. And then she will be followed by a very dear friend of mine, Mr. Jason Ricketts, who will be speaking on COVID-19 and healthcare systems in the Caribbean, the experiences of persons with disabilities. But before Dr. Edwards begins her presentation, I wanted to just do a little bio to introduce Dr. Edwards. Dr. Edwards is currently a lecturer at the University of the West Indies, Mona, within the Mona Aging and Wellness Center. She's a medical doctor and registered physical therapist, and she lectures in the areas of public health, gynecology, and geriatrics. I'm not sure if I pronounced that second one correctly. Dr. Edwards will, of course, advise. In addition, she serves as a member of the vaccination team at the Mona Aging and Wellness Center vaccination site. Dr. Edwards, over to you, and thank you very much.
Hello, good afternoon. Thank you so much for the invitation. Thank you for having me. Good afternoon to everyone. So yes, I'll be presenting on a paper that was done entitled Facilitating COVID-19 Vaccine Administration to Persons with Disability, Best Practices Based on Service Delivery at Mona Aging and Wellness Center vaccination site at the University of the West Indies, Mona. So these are the co-authors, and I have the privilege of presenting on their behalf. And just an overview of just what's happening at Mona Aging and Wellness Center over the last, I guess, years, 2 years, a year, concerning the vaccination drive. So Mona Aging and Wellness Center began administrating COVID-19 vaccine on March 22nd in partnership with the Ministry of Health and Wellness Jamaica as part of the National Vaccination Program, which aligns the World Health Organization's Strategic Advisory Group on experts on immunization values, framework, and allocation and prioritization of COVID-19 vaccines. So the clinical manifestation of COVID-19 disease range from mild to severe respiratory and non-respiratory symptoms. And since becoming publicly available, COVID-19 vaccines have been strongly recommended by authorities in health as an effective and safe measure to reduce the risk of infection with the virus that caused COVID-19. The risk of severe disease with infection and hospitalization and death are also reduced in fully vaccinated individuals. Along with hygiene measures, physical distancing, mask wearing, testing, and treatment, COVID-19 vaccines are believed to be the key to controlling the pandemic. So persons with disability often face barriers when accessing health services, with attitudinal as well as physical barriers being among the most common. Vaccine administration's efforts should actively seek and should always actively seek to minimize barriers and increase accessibility to vaccine services. So in this paper, the elements of COVID-19 vaccine administration program in Jamaica was discussed and described successful approaches utilized at one of the vaccination center or site, specifically Mona Aging and Wellness Center. And this is to ensure persons with disability to have safe, supportive, and dignified access to COVID-19 vaccines. So looking at COVID-19 vaccine program in Jamaica, and this is just a design overview and how it serves as a template and a foundation for the administration of COVID-19 vaccines. So vaccine administration is an established public health strategy and preventive service offered in Jamaica. Nationally recommended childhood vaccines are offered at no cost to clients in the public system, and this is under the expanded program on immunization, and this is the country's main vaccination program. There are optional vaccines that are available within the public sphere, such as yellow fever and influenza vaccines. Private healthcare providers also offer nationally recommended vaccines and optional vaccines as well. So in last year, specifically March 10, 2021, COVID vaccine became available in the Jamaican population. And this is exactly 1 year after the country identifies first case of the COVID-19 disease. And to guide the national COVID-19 vaccine administration program, the country's Ministry of Health and Wellness designed an implementation plan targeting 65% vaccination coverage by March 31st, 2020. The vaccination program would see vaccines being administered initially and mainly through the public health system at no cost to the clients, with subsequent establishment of public-private partnership to increase vaccine accessibility and uptake. So in dealing with the COVID-19 vaccination implementation plan, the WHO had adopted the World Health Organization Strategic Advisory Group on Experts on Immunization, which is WHO SAGE. And this is this really focuses on the allocation and prioritization of COVID-19 vaccines. The framework views COVID-19 vaccine as a global public good, which should contribute significantly to the equitability or equal protection and promotion of the human well-being among all people of the world. In looking at the equal respect principle, this calls for an equal consideration for all individuals and groups in decision-making and actions related to vaccine allocation and priority setting. It also calls for the offering to all prioritized individuals and groups of a meaningful opportunity to be vaccinated. The other principle, which is a principle of national equity, requires that vaccine prioritization considers vulnerabilities, risks, and needs of groups that are likely to experience more significant burden from the pandemic due to social, biomedical, and geographic disadvantage. It also requires further that implementation system and infrastructure be put in place so as to allow persons with disability to have equal access to vaccinations. So the Ministry of Health and Wellness had implemented a phased approach, and this was taken for the vaccination administration in Jamaica. So in phase one, vulnerable populations, including healthcare workers, older adults, and the security forces were targeted. Populations essential to economic activity, including workers in the public sector, tourism industry, agriculture, and banking were targeted for phase 2, and members of the general population were the focus of phase 3. And this approach was due to the expected limited availability of vaccine at the start of the program in March of last year, and subsequent acquisition arrangements, which would not be entirely within the country's control. So looking at disability and the health services, it's important to note that it is estimated that approximately 15% of the global population lives with some form of disability. The literature acknowledges that persons with disability experience discrimination and barriers that hinder them from participating equally with others. And these occur throughout the entire social sphere, including healthcare, and are more common in the low and middle income countries. Cultural beliefs about disability and unfavorable attitudes toward persons with disability can act as barriers in both the provision and utilization of healthcare services. How health information is disseminated can also exclude persons with certain disabilities, such as those affecting vision and hearing. There are also practical and logistical barriers which create environments and service delivery modalities that are not accessible for persons with disabilities. In the 1991 census, this census actually represented the first attempt to capture this information of the disability in Jamaica, and the efforts being spurred on really by increasing recognition internationally of the rights of persons with disabilities. It was determined that 4.6% of Jamaicans had a disability, and in 2001, 6.1% of persons acknowledged having any disability or infirmity, while 2.7% persons indicated that the disability or infirmity limits their activity compared with most persons of the same age. Data from the 2011 census revealed that the percentage of persons 15 years and older reporting some difficulty with at least one of 7 named activities ranged from 1.8% for communicating to 17.7% for seeing. Jamaica has demonstrated commitment to ensuring the right of persons with disability and promotion inclusion with this accommodation. In 2007, Jamaica signed and ratified the United Nations Convention of the Rights of Persons with Disability. The recent coming into force of the 2014 Disabilities Act, and this was recent, meaning February 14th of this year. And this is another indication of the country's commitment. Although these instruments articulate health entitlements and provisions, there is evidence to suggest more is needed in the operationalization of the ideas. In a recent analysis of disability, chronic diseases, and access to healthcare in Jamaica, persons with disability were described as regular users of services within the health sector. So how does the COVID-19 vaccination program affected the persons with disability? So persons with disability may be disproportionately impacted by COVID-19, and the risk of infection may be higher due to several factors, including inability or difficulty to practice physical distancing because of caregiving or support needs. It could be because of reliance on physical contact with the environment, and or a barrier caused by information dissemination not reaching to the disabled population. And so there is a reduced access in COVID-19 information in persons with disabilities. Persons with disabilities may also face greater risk of death with infection due to underlying health conditions related to their disability or inability to access healthcare in a timely manner because of their disability. Disruption in health and other service or support service due to the pandemic may also increase the risk of developing new or experiencing worsening existing conditions. And these factors warrant that disability must be considered within the vaccination program. Of note, persons with disability were not singled out as a priority group for the COVID-19 vaccination program in Jamaica, but rather persons with disability who belong to a named priority group would receive the vaccination once they fit into that group. So looking at Mona Aging and Wellness Center as a vaccination site. So the Mona Aging and Wellness Center is located at Mona campus at the University of the West Indies. And this center began administering COVID-19 vaccine on March 22nd, 2021 in partnership with the Ministry of Health and Wellness in Jamaica. The Mona Aging and Wellness Center vaccination site operates within the Kingston and St. Andrew Department of the Southeast Regional Health Authority. The center, which is research-based and training-based, and which has a history of evidence-based outreach and advocacy for older persons, began offering COVID-19 vaccines to the priority group of persons 75 years and older. Mona Aging and Wellness Center's partnership with the WHO continued as other priority groups were named, and the center was later established as a fixed vaccination site. The Ministry of Health and Wellness data indicated that as at March 16, 2022, 57,597 doses of COVID-19 vaccines have been administered at the Mona Aging and Wellness Center, accounting for 4% of the total doses administered in the country. Although disability status was not captured on the client registration form, and that's a form for the vaccination, vaccination site personnel at the Mona Aging and Wellness Center confirmed that the majority of the clients served at this center were without disability. One survey that was done, and this was done of 427 clients conducted by the Mona Aging and Wellness Center from June through to September of last year. And they inquired about persons with disability, specifically physical, hearing, and vision impairments. And they identified that approximately 9% of persons were identified with at least one disability. Now, looking at the best practices as delivered at the Mona Aging and Wellness Center, these best practices are really practice recommendation. And they are in keeping with WHO SAGE as well as Ministry of Health priorities. So the aim of delivering vaccinations to persons with disability on the basis of providing reasonable arrangements to allow access to vaccination sites as well as the vaccines. So this practice recommendation is ingrained in the Disability Act, as is also in keeping with the WHO SAGE on the principle of equal respect, which was mentioned earlier. It seeks to enhance access to making adjustments that are not unduly burdensome to ensure a person with disability can participate, in this case, get vaccinated in an equal way to others without disabilities. So Mona Aging and Wellness Center did this by undertaking minor infrastructural upgrading work, such as smoothing out rough walkways, which posed trip hazards, and installing handrails inside the building at potentially difficult spots, such as slide with unexpected inclines. And these actions, of course, improve safety and reduce the risk of falls. In-car vaccination services were provided. where clients with physical and or mental disability receive their vaccines in their car, in their vehicles. This removes the burden of navigating an unfamiliar space, which may be particularly difficult and stressful for a person with conditions such as dementia, autism, or just having mobility issues. What was also provided was assistive devices such as walkers or wheelchairs when they were necessary and needed. At the Mona Aging and Wellness Center, we provided support for paper-based registration activities. So the registration process outlined by the Ministry of Health and Wellness requires that persons complete paper-based registration forms, even if information was supplied electronically. And so personnel at the Mona Aging and Wellness Center were able to assist persons, particularly with visual impairments, to complete the exercise, and so were able to be processed for the vaccination. Clients were also allowed to be accompanied by their caregivers or interpreters. To prevent overcrowding, the general protocol allowed for one client to be present in the vaccination room, but this was modified for a person with disability who needed a caregiver or an interpreter to be present and ensure provision of services on an equal level to other clients. For example, deaf clients accompanied by their interpreters to understand vaccine information being relayed verbally by healthcare providers. A telephone and social media communication channel was established, and this enables information, specifically site-specific information, to be disseminated, and also to allow for the broader Ministry of Health information to be disseminated among persons who have disabilities. The other practice that was done at Mona Aging and Wellness Center was one that ensured that dignity was upheld. So we prioritize the maintenance of dignity in service delivery at all times, especially with persons with a disability. And this recommendation stems from a key tenet of human rights, which recognizes inherent dignity and worth of all persons. Health and other services should be delivered such that each person's dignity is upheld. And the Mona Aging and Wellness Center did this by employing a fast-track system as needed. So staff members were sensitized to certain situations where a fast-track approach would be needed. For example, where the client has physical or mental disabilities and would find a prolonged wait time difficult to endure. Individuals, particular members of the Mona Aging and Wellness Center vaccination site would pull these individuals from the queue and facilitate them, or they will be given in-car service. Also, respect for all was emphasized. Staff members were advised to be respectful and discreet in all dealings with clients and to avoid responding in ways that could cause embarrassment because of their disability. Another method that was utilized is actually using vaccinators with relevant experiences where possible, of course, for clients with mental and cognitive disabilities. And there were times when persons will come and they will have a cognitive disability. They're out of their space. They're in a new space. There's crowd and they're uncomfortable. And persons with relevant experience will be called in, and they would cause the whole vaccination process to be a calming one. And so this helped to improve the chances of acceptable and efficient vaccination administration. So in conclusion, persons with disability are a diverse group, both in terms of their disability and in relation to their social and economic backgrounds. As members of the general population, they are impacted by COVID-19, and there is evidence to suggest that they may be at increased risk over a person without disability in some cases. Health service providers offering vaccination services should know that there are important actions to be pursued to ensure equitable access to COVID-19 vaccine by persons with disability. The strategies employed by the Mona Aging and Wellness Center are commendable, and some may even be applied to services other than vaccination. And I thank you so much for listening.
Thank you so much, Dr. Edwards. That was very, very, very interesting. I'm going to open the floor for any questions at this time. Are there any questions?
Hello.
Yes.
Floyd Morris here. I
Hello,
just
sir.
wanted to, yeah, man, pleasant good afternoon and
Good afternoon,
very good
to you.
presentation.
Thank you.
And I was looking forward to this presentation and actually, you know, have a keen interest on getting it published in the peer-reviewed book to come, because, you know, we have to make sure we capture the experiences in terms of COVID-19 and persons with disabilities. But I wanted to find out, I don't know if I missed it in your presentation, if you actually had an actual figure of persons with disabilities that came through the Mona Aging and Wellness. So you actually have that.
Right.
You could just remind me of it, because I'm very curious to see what was taking place. You know, because this sort of detailed information is not available elsewhere. I mean, we have not been able to capture that sort of details from other other locations in the Ministry of Health.
All right, so what happened is that on the vaccination registration form, there was nothing there to indicate disability.
Right.
So at the Mona Aging and Wellness Center, a survey was done, and this was done between June of last year and September of last year. And it inquired about physical disability, hearing and vision impairments. And the survey looked at 427 clients. And they identified that 9% of these persons had at least one disability.
Can I say something, please?
Let me just find that slide so that we can have a visual. So there it is.
Me that slide, Doc.
So one of the surveys, so the survey was done on 427 clients, and this is an unpublished data. This was done at Mona Aging and Wellness Center and was done by the staff member. And it inquired about physical health, physical disability, hearing and vision impairment. And it identified that 9% of persons had at least one disability. So I said earlier that unfortunately that the registration form that you register to get the vaccine, it does not say or ask for disability. There's no way that you will tick to say disability or indicate what kind of disability you may have had.
Can I say something, please?
Sure, go ahead.
Thank you for that presentation. I'm one of those persons who had or was vaccinated at the Mona Age and Wellness Center, and I have about 3 other persons who I know that went there, and I must say the service was awesome.
Thank you.
In fact, when my wheelchair came out of the car, they said, "No, ma'am, put it back in. We will come to your car."
Okay.
And the form was given to me, and it's true, they did not ask about my disability. But what was even interesting, apart from getting the card there, I also received online the document from the Ministry of Health.
Okay.
So I was able to print it and staple the card that I received at university to say that, yes, I did receive my vaccination there. But you're correct, no question was asked about our disability. But the moment they saw that I was going to be using a wheelchair, they put it back in the vehicle and everything was administered by the vehicle. So I was well received.
Very good. I'm glad.
Right, thank you for that. And I'm happy as well that you got an excellent service, or you had a very good experience with the vaccination procedure. Any other questions? Okay, well, if there are no other questions for Dr. Edwards, the reality is that your presentation was so thorough and was so easy to follow that I believe that that's why there are no questions. It was very easy to follow. The information was good to digest. And so that's perhaps why we have no questions. But thank you very, very much.
You're welcome. Thank you for having me.
Yes.
Miss Powell.
Yes, sorry, go ahead.
Yes, well, just one comment. Gloria Goff here. I am one of those persons who did my first shot at the Mona Wellness Center, and I found the service awesome as well. But I think they might sometimes, being so awesome and being so accommodating, some things get left. And I think what I found is that I mean, by the time I got there, I was like out of there. So they really accommodated me, put me to sit down and everything else. However, I was not the beneficiary of the little counseling sessions that they had, because I heard people on one side talking, then a lady responding and explaining all about the virus and what they need to do and what they need to take. And I wasn't the beneficiary of that. So apart from the doctor telling me, you know, you can take Panadols and so, but the other things that they normally talk to you about, I did not benefit. So I'm wondering now that I'm hearing that people were treated at the car, whether they were also, whether they were beneficiaries of the mini counseling program that is done.
Yes,
so
I was.
Because I was one of the doctors who administered the car vaccines, and each person was counseled.
Yes, I was, and I was even given Panadol by the doctor. So I was spoiled by the doctor there as well. And then
Dr.
he told me what to
Edwards,
do afterwards. 4 hours after, I was
thought I knew already.
Dr. Edwards, it seems as though I should have come to your side.
Yes. Can come and get the booster.
I
haven't
missed that
gotten it yet.
opportunity. Yeah. Yeah. Well, thank you once again. Thoroughly appreciated. I'm going to, we can move now into Jason's presentation. I'm just going to introduce Mr. Ricketts. I'm sorry, I'm saying Jason is a familiarity sometimes. But like I said, Mr. Ricketts is a friend of mine. Jason Ricketts is the holder of a bachelor's degree in media and communications and a minor in international relations with a master's degree in communication for social and behavior change from the University of the West Indies. He recently started his doctoral studies at the University of the West Indies in 2021 with a focus on sports. He's a certified peer counselor as well as a disability advocate. He's also represented Jamaica in multiple sporting disciplines, namely blind cricket and track and field. And he has also represented the West Indies in 2 T20 Cricket World Cups for the blind in 2012 and 2017. This afternoon, I would like to welcome Mr. Ricketts, who will be doing his presentation. Let me just remind us of the topic, if we have forgotten. COVID-19 and healthcare systems in the Caribbean, the experiences of persons with disabilities. Thank you. Over to you, Mr. Ricketts.
Good afternoon, ladies and gentlemen. Thank you for that lovely presentation or introduction. Now, it is a well-known fact, or it's a widely held view by many throughout the Caribbean that the collective health system is less than ideal at the best of times. This has been made worse with the onset of the COVID-19 pandemic, which has hamstrung or further hamstrung the health sector, which was already failing to meet the needs of those it was designed to assist. One group of individuals who know this all too well is persons with disabilities. These individuals have already experienced and endured their fair share of tribulations, and if left unabated, further serve to disenfranchise them. As the adage goes, the youth are the future, and it is time to hear from them. 6 talented, smart, engaging individuals will present on the various experiences throughout the Caribbean, as well as make recommendations, as well as outline their dreams and aspirations going forward. Now, we will start with Ms. Jessica Jacoby from St. Lucia. Now, Ms. Jacoby, despite being blind, is a staunch disability advocate, and she is the first blind St. Lucian to graduate from the University of St. Augustine. So, Ms. Jacoby.
Good afternoon.
Hello.
Hi, good afternoon.
Yes, go ahead.
Yes, it is indeed a privilege to be present at this conference, and I would like to thank Mr. Ricketts for the invitation. So my presentation is on the impact of COVID on persons with disabilities in St. Lucia when it relates to healthcare. According to the 2010 National Census in St. Lucia, about 12% of our island population represents persons with disabilities. And St. Lucia on June 12, 2020, became the 181st UN member state to ratify the UN Convention and to accede to its optional protocol. And interestingly, that was really when we were in the heart of COVID, in the beginning of COVID, when the world was in a more or less in a state of panic. And we were grateful that this happened because there was a great deal of advocacy by our national organizations, our regional and international partners as well. The COVID-19 raised its ugly head in St. Lucia and further marginalized the persons with disabilities. Quite rightly so, according to Isles Brands Keris, I hope I'm pronouncing it correctly, the Assistant Secretary General of Human Rights of the UN. Persons with disabilities are among the most adversely impacted by the pandemic, with disproportionate loss of lives and impact on health as well as livelihoods. Generally, access to healthcare services and facilities was and is an area of great concern in St. Lucia. However, the Ministry of Health has to be as they went out into the communities, to the homes and institutions where persons with disabilities and other persons who were not able to go in to get their vaccine, the vaccines were taken to them. And so they were unable to access the clinics, it was taken to them. Our national hospital was converted to a respiratory hospital because we had a new hospital in waiting that was not yet in use. So with COVID-19, we were forced to begin using the new hospital, and the old one was made into the respiratory hospital. Unfortunately, that hospital, the respiratory one, is not very accessible, I must say, for persons with disabilities. It was built quite a while back, so it was not made really, I guess, taking into consideration the needs of persons with disabilities. But we have our other hospital, the Owen King European Union Hospital, which is very accessible for persons with disabilities in terms of the infrastructure. And there are some challenges when it comes to sensitization of staff, but it is decent enough. And I'm speaking from personal experience a few weeks ago. So generally, this is due to the pandemic and other global factors, the cost of healthcare is rising. There are services that persons with disabilities can access through the public facilities and the public healthcare facilities, and those who are beneficiaries of the social assistance program and hold exemption cards can access additional services, for example, laboratory services, but others who do not have this privilege have to find the finances from their already stretched, limited resources to be able to meet their healthcare needs. There is a significant level of access to healthcare information for persons with disabilities during the pandemic, as long as one has access to the media. Information such as COVID-19 protocols, national statistics, vaccination sites, etc. is provided. Sign language is sometimes incorporated in some of the addresses and public service announcements. But this also includes, and when I speak of the media, it also includes the social media. So a lot of persons could have gone online and accessed the Ministry of Health or the government of St. Lucia's Facebook page, the Twitter page, whatever other accounts on social media they were able to access or are able to access. So this is good, but persons who do not have this facility and may live alone are not able to access such. So we still have some shortfalls. A number of persons with disabilities were challenged in attaining their basic needs, such as food, early during the pandemic, as sometimes the public and disability financial assistance that they rely on heavily was severely delayed. So I'm not sure what was happening with the government system at the time, but many persons complained. So persons would have to resort to, sometimes they receive packages from other organizations, and it would have some basic things that can be used, but when it comes to having proper food and working with healthy living, it was a real challenge for them. And it's still sometimes, because you have to end up using what it is that you get and not necessarily what it is that you need. When addressing persons with disabilities needs, if the person does not have a mental disability, this aspect of one's life is trivialized or totally ignored. And I'm sure many persons around the Caribbean and internationally can relate. So they only focus on the fact that maybe you are blind or you have a hearing impairment, but they do not focus on the mental aspect of coping with a disability and coping with a pandemic, having a disability. During COVID-19, persons with disabilities have expressed feelings of loneliness, fear from uncertainty, frustration, boredom, fear of contracting COVID, and so many other emotions. Those who cannot afford or have no access to technology experience limited or no social interaction with their peers here and abroad, and so this impacts them negatively. One of the things I must say I commend our government for, again, our Ministry of Health, is they developed this hotline 311 where persons can call in if they had questions about COVID, if they were having any challenges that they were having COVID related. And one of the services that they provided was counseling. And for me, this is one thing that could have really helped persons with disabilities. And that started very early during the pandemic. So persons could have called in and, been provided with some level of counseling. The challenge with that, though, is I am not sure, I'm being very careful in choosing my words, that the persons who were employed to provide this level of assistance were sensitized or trained as to how to take into consideration the issues related to persons with disability. In ensuring that during and post-COVID, persons with disabilities remain part of our national health agenda, existing policies need to be revised. This is my hope and my dream and my expectation and what it is that I'm working towards, that the policies need to be revised and new policies to be developed and implemented. These policies must be guided by Article 25 of the UN Convention on the Rights of Persons with Disabilities, the World Health Organization guidelines, and the Sustainable Development Goal 3, which emphasizes that to achieve the overall health goal, St. Lucia needs to achieve universal health coverage, provide access to quality health care, and make provisions so no one is left behind. Thank you very much.
Thank you. Thank you very much. Are there any questions or comments at this time?
And remember, Ms. Mackenzie, it's 3 minutes. And Ms. Mackenzie is a second-year university student who is currently pursuing a bachelor's degree in psychology with an emphasis on health.
Good afternoon, everyone. Am I allowed to share my screen?
Yes, you can.
Yes.
Okay, thank you. Hey, good afternoon, everyone, again. I am Gabrielle McKenzie. I live in Guyana, and I have been. Today, I would just want to have a short discourse with you all on the healthcare and persons with disabilities in my hometown, Guyana. For my discussion, I'll be touching on the most common barriers as it relates to receiving healthcare services in Guyana, and also the impacts of the COVID-19 pandemic on healthcare services for PWDs in Guyana. The first barrier that I will be highlighting is the physical barrier, which involves the difficulty to access restrooms, entryways in a health facility. And this happens mostly to wheelchair users. I have also personally faced difficulty with using medical devices or instruments like the X-ray machine. There's always confusion and chaos for me to use an X-ray machine, and that's because there's no appropriate facilitation for PWDs. This issue kind of the hassles, when you think about the hassle in receiving medical service, I kind of avoid medical checkups, which is, even though it's very necessary for my condition. The next barrier that I wish to highlight is the attitudinal barrier, which involves discrimination by healthcare practitioners and other professionals in the health facilities. This tends to happen a lot in departments that deal with sex health, and happens a lot towards women with disabilities as well. You know, persons, staff, especially in the health setting, they tend to believe that because someone has a disability, someone cannot see or they can't walk, they should not be inquiring about certain things like contraceptives. However, we are in 2022, and I believe it's high time for these perceptions to change in order for us to feel comfortable, us meaning persons with disabilities, to feel comfortable about seeking information in how to take care of our bodies. The last barrier that I wish to highlight as it relates to challenges for PWDs in Guyana is the communication barrier, which is mainly faced by individuals with hearing impairments. In Guyana, I actually do not know of any health facility, both in the private or the public sector, with a sign language interpreter. Also, there is limited or no availability of written materials in these facilities. It is very important to know that always needing to have somebody accompany you in order to receive a medical service actually infringes on patient confidentiality, and it also infringes on a fundamental human right, which is privacy. So those are the three most common barriers that I wish to highlight. And now I'll just be touching a little on COVID-19, the COVID-19 pandemic, and the impact it had on the healthcare service for persons with disabilities in Guyana. So with the arrival of the COVID-19 virus, the challenges between PWDs and the healthcare services in Guyana have evolved in a different but related direction. During the fight against the disease, the needs of people with disabilities have been pushed aside. Firstly, physiotherapy and physical care was hampered. Many persons with disabilities, those with physical disabilities that is, who require daily physiotherapy, have been left in much discomfort and pain as a result of the many COVID restrictions. Another issue was that mental tensions among the parents and children intensified. So many parents of children with learning disabilities, they were unable to obtain daily care for the children, and it resulting in substantial mental tensions among both child and parent. For example, some children with autism are regularly taken care of by professionals at these institutions. However, since the pandemic and you cannot access the institutions, parents had to take up a heavier role in their children's daily care, which resulted in a lot of mental tension. Another issue that went unnoticed is the medical needs being neglected by the pharmaceutical industry. The pharmaceutical industry are known as the money makers, and during the pandemic, they have been focused on distributing and producing high demand items and products, which in doing so, they disregarded drugs and supplies that were not as necessary in their eyes. Many of the drugs and the supplies that were excluded were products that PWDs needed as part of their treatment plan. I know that this issue, it was big for me because it affected me as well and my friends in the disability community. You know, you go every week for a supply or a medication and you're hearing, no, we're not dealing with that right now. So that was a very frustrating time for us. Now, as it pertains to how PWDs were protected against the virus and how we helped with protecting others, I know that many PWDs...
Gabriel, you have to wrap up now.
Pardon?
I'm saying you have to wrap up. You have exceeded 3 minutes.
Okay, sorry. So, okay, as we stay here and discuss our experience and perspectives, I sincerely hope that the revelation of these facts that happened during the pandemic and in our society result in positive changes in our communities and countries at large. Thank you for listening to my presentation.
All right, thank you very much.
Now go to Miss Belisha Clark. She's from St. Kitts and Nevis. She's deaf, as well as also a trained cosmetologist.
You're gonna have to turn on the camera, allow it to turn on the camera. So you could see and she's signing.
Camera. Belisha Clark. Yeah, you're a co-host. Your camera is on. You can go ahead now. Interpreter, you need to turn on your mic. Go ahead now. You can go ahead now.
Okay, I'm here to talk about the COVID-19 pandemic and experience of persons with disabilities. The COVID-19 pandemic really exposed a lot of weaknesses and gaps in the healthcare system in the Caribbean. We noticed that most of the healthcare facilities in the Caribbean had challenges with facilities like hospitals that were very small, and also other small islands we know have the same challenges. For example, you could see that there was a lack of specialists. There was also an increase of patients. There were staff who was burned out and experienced a lot of stress. There was technological and communication issues. And also there was a shortage of clinical supplies. So these are challenges that were faced by several of the small islands. We saw overall that there was a decline in the number of clients who were accessing the health services. And this was at the various health centers. And we saw that in the year 2020, this includes persons who have hypertension, also dental services, cancer screening, and also child health, toddlers, and other family planning clinics. But there was some recovery since 2021 until the present day. Mental health service delivery was the only exception to this trend. There has been an increase in the number of clients that were attending and also accessing mental health services. There was also a notable increase in the number of patients who were diagnosed with depression and schizophrenia. This may, yes. This may have been partially because of the psychosocial stress that persons faced during the COVID-19 lockdown. We were not as prepared as we should have been. But the same can be said. The same can be said for most of the world. The difference was that the larger and more developed nations, they were able to recover more quickly because they had more resources and money to purchase the necessary supplies. Masks, for example, masks and vaccines. Speaking to the experiences of persons with disabilities,
Mr. Mills,
one
you have
mother,
to wrap up now.
mask wearing was a problem for some persons that had certain disabilities. For example, persons who had with autism, persons who have Down syndrome, and other sensory impairments. Also, there is the testing requirement, which I understand, but persons with sensory issues are not easily tested, and sometimes they're not tested at all. In most settings, there was no one to do sign language, and that presented an even greater challenge than usual because critical information was not available to the deaf and hearing impaired community. Getting tested and communicating symptoms to medical personnel proved very difficult for persons with various disabilities. persons who couldn't speak or had major speech impairments. They also face major communication issues.
Okay, thank you so much for that presentation.
Okay, so
it is very
this
appreciated.
Right, this is all right. So in conclusion, not much provisions were put in place for persons with disabilities to ensure that they were made aware of the daily situation on the ground or had equal access to goods and services during the lockdowns.
Thank you very much. I thought you were, yes.
Ms. Powell,
I thought you were
we
finished.
only have 2 presenters remaining. Next
Okay.
one is Ms. Judy K. Sango, and then Deandra Smith in that order.
Okay, thank you.
And 3 minutes, Ms. Sango. You can stop sharing your screen now, Ms. Clark. All right, Ms. Sango, you can go ahead and share your screen. Ms. Sango? All right, Belisha, you need to turn the camera off. All right, we have to skip Ms. Sango. No, Deandra, are you ready?
Good evening. Yes, I am.
Yeah, you can go ahead. And remember, 3 minutes.
So good evening, everyone. All protocol is observed. I would first start by saying that myself, as well as other members of the disabled population, recognize and appreciate the work of the Jamaican government, as well as other stakeholders who have really invested a vast amount of resources to ensure our education, as well as our public socialization, is always protected. Today, I'll be speaking about the experience of persons with disabilities throughout the years of the pandemic, which represent the period between 2020 to 2022. Have you ever wondered how long it takes to walk across the ocean without a pair of slippers? Only Jesus made that possible. And today, I am here to make disability, life, and healthcare matter. The COVID-19 pandemic has left many of us out of touch with reality, forging for our life, which eventually led to the disappearance of our social life. Firstly, persons with disabilities are not more susceptible to COVID-19. Therefore, the question is asked, what level of medical assessments were present throughout the years of the pandemic, safeguarding the most vulnerable, heightening access to regular medical assessments? Our flourishing youth were told to take the highway each time they traveled to public and private healthcare facilities, pleading for a routine checkup in the name of discovering whether their disability had worsened amid COVID-19. Why complain though? Have you heard of this? An astonishing number of our community had no access to the medication they needed for surviving profound impairment. Excuse me, you've gone silent. Didn't you choose the importation of masks over our medication? Secondly, disappearance of our social life. Persons with disabilities are more likely to be excluded from social events. However, usually, persons with disabilities depend heavily on social events to gain exposure. Throughout the pandemic, persons with disabilities received the WIP, as government ended public socialization, ensuring persons with disabilities were excluded, remaining in their woods of isolation. Did anyone get an invitation for a mental health awareness program? Promoting mindfulness for the disabled population defeated once more. Medical professionals failed to offer or encourage mental stability for our community and directed their efforts elsewhere. Didn't you choose the importation of masks over our medication? By this, the campaign for vitamin C had intensified, and we were told to purchase the most scientifically approved vitamin C. This caused us to rush towards the pharmacies, competing for the most expensive brand. I know, vitamin C is an effective supplement that aids in the repair of our body tissues, contributes to the immune defense system, which ultimately prevents harmful virus from entering our bodies. It possesses an inexplicable power that strengthens our immune system, saving us all from the dreadful disease, which is COVID-19. How much of us realize the level of exposure we've received traveling on those public passenger vehicles, rushing for the pills we were told would save our life? Yet, many of us still contracted the virus. Didn't you choose the importation of masks over our medication? As an aspiring educator and advocate, I hereby propose that the medical team reevaluate how it handles a pandemic while ensuring the healthcare and routine checks of the disabled is prioritized. Offer therapeutic sessions and promote mental health care for our community while distributing self-help resources. The medical team knows their patients. Keeping a record of those with permanent disabilities will increase the communication between medical personnel and agencies responsible for the disabled population. I will continue to work collaboratively with members of our community to ensure our disabilities are the opportunities we need to strive. You've heard my heart, you heard my soul. Now take these words and always be proud of who you are. Thank you.
It's over to you now, Ms. Powell.
Yes,
Tamisha?
thank you very much. Thank you. We traveled today with our ears and our eyes to hear the experience of our brothers and sisters across the region. Are there any questions or comments at this time? Any questions? I want to thank everybody for sharing. I think that sometimes we take it for granted, the experiences. I believe it was the previous presenter, not the last person presented. She had indicated the difficulty sometimes when there's a sensory disability, just with little things like getting care. And we have to really be mindful of that. So we appreciate the opportunity to remember that when we're doing anything, when we're setting up any sort of support, any social interventions, for lack of a better word, we have to be mindful of everybody, because everybody has to be equally provided for. So thank you very much for that. At this time, I believe my session is ended. And so I'll hand back over to the official chair for the day and say thank you very much for allowing me to participate. As always, it's always great learning experience for me. So thank you, everybody. And thank you, Mr. Ricketts.
Thank you. Thank you very much, Ms. Tamisha Powell, for conducting, for managing, for steering this session. in which we heard from Mr. Ricketts and his team. And it was wonderful to hear the views of persons, not just from individuals, not just from Jamaica, but other countries in this session. But if you notice, the views remain similar, having the same challenges right across the region, and I think globally. COVID-19 is still around, and based on all predictions, will be around for quite a while. And although things have kind of slowed in terms of the infections and hospitalization, it doesn't mean that we're to totally drop our guard. All right, so now we move to our final session for the day, and that is session 9. And we have two presentations, but unfortunately, due to circumstances beyond the person's control, that is Miss Carrion Eiffel, who would have presented on reimagining the training of healthcare professionals in the Caribbean, she will be unable to do so. And oh, how we were looking forward to it, because it has been a thread through almost all presentations. However, I'm sure she'll get an opportunity to share it at some other point, and I'm sure that Dr. Morris will ensure that he collects the presentation and includes it in his peer review. All right, so we'll move to the final presentation for the day, evaluating the Mona Dental Polyclinic, and that is Deaf Dental Care Initiative. And we have Miss Charmaine Robotham to moderate this session. Over to you, Charmaine.
Good afternoon, everyone. It's my pleasure to be the moderator for the final session. And we have saved the best for last, one would say. And so let us move right now into the final presentation, which is evaluating the UWI Mona Dental Polyclinic Deaf Dental Care Initiative. Our presenter is Dr. Karine Cumberbatch. The corresponding author is the Deaf Clinic Coordinator at the UWI Mona Dental Polyclinic. She's also a lecturer in linguistics in the Faculty of Humanities and Education, Sign Language Linguistics, Deaf Patient Communication, and Adult Education are among her key research interests. Welcome, Dr. Cumberbatch, and I understand that you have 20 minutes for your presentation.
All right, thank you very much. I'm going to share my screen. Can everyone hear me clearly? Can you hear me clearly? All right, so they're hearing me. So I'm here with Dr. Alexis Garcia. The two of us are going to be doing this presentation, and Dr. Jones is going to lead the question and answer segment. And just for the interpreter's sake, to make it easier for him, I'm just telling the interpreter, this is my name sign. And Dr. Jones is this. That's me, and this is Dr. Jones. Yeah. All right, so I will be starting the presentation, and then I will hand over to Dr. Alexis Garcia to continue. So as you see, our title is Improving Dental Treatment Outcomes Through Direct Communication Between Student Dentists and Deaf Patients. And it is done in the Squire reporting guidelines. So it's a Squire explanation and elaboration on a Deaf Dental Care Initiative at the UWI Mona Dental Polyclinic. It's a huge mouthful to say, that we went through different processes to make sure that our deaf patients felt as though they were on equal footing with the hearing patients. So the impetus for us came when we saw the 2013 CARICOM declaration. We were already discussing on campus ways to include deaf through Dr. Jones, who was coming on staff as the head of the School of Dentistry. And he insisted that all the dentists must sign, and he built that into the program. So it is actually a graduation requirement. You cannot graduate from UWI Mona as a dentist unless you have sign language competence. And when we saw that was happening in 2011-12, and when we saw in 2013 that CARICOM made this declaration, we were so happy because it bolstered what we were doing. So as you see, CARICOM said that we resolved to take the necessary steps towards building a physical and social environment that promotes the habilitation, rehabilitation, and integration of persons with disabilities. And it goes on to talk about social and health services, and that is what we were holding on to. We also looked at the UMDP. So with the UN CRPD, which in Article 25 said that persons with disabilities have to be provided the same range, quality, and standard of free or affordable health care and programs as provided to other persons. And they also said that it requires health professionals to provide care of the same quality. So it was not just that the people would come in and have access to it, but the health care workers had an onus on them to also do what they needed to do. And the response of the UMDP, that's UWI Mona Dental Polyclinic, is to create an intervention that will integrate the deaf citizens in Kingston first and then throughout Jamaica into dental care by creating direct communication access. And this is what we did. But then we had to test to make sure that our plan worked. So this whole presentation is about how we verified that our intervention was successful. So the first thing that we did was to look at sign language acquisition. So we decided to go with natural sign languages rather than an artificial sign language. And some people know what that would mean. Natural sign language has its own grammar, and it is not dependent on spoken language for its structure. So for example, Ms. Belisha Clark, who presented from St. Kitts and Nevis, was using signed English, which is an artificial sign language, which is sometimes used in formal occasions and in the education setting. But what we wanted is to use what the average deaf person on the street would be using. The natural sign language does not follow in the same way. So many people who learn from books, for example, when they learn from a book and they say, I met a deaf person, or I learned sign language in church and I met this deaf person and I can't understand what they're signing. And that is because it's a totally different grammar and the vocab is not necessarily the same. So we wanted to ensure that when a deaf patient walks in, our students would know. So we didn't opt for signed English. We chose to use sign languages of the Caribbean. And our classes have students from across CARICOM, and we would tailor what they learn to ensure that they know what the deaf in their country would be using. So we started off with beginners level, where they would do the general everyday life domain. And this is at the preclinical phase. They would learn things like how to introduce themselves, how to give directions, how to find out demographics from a patient. All of this is in the general domain. And then we move to the healthcare domain in a separate course, where they learn things having to do with procedures and patient management. How do you tell a patient to turn their head? How do you tell a patient that this is the procedure you would need and these are the side effects, these are the complications, to make sure that they would have knowledge to give informed consent. How do you explain to a patient how to take a particular medicine? So that is what they would learn in the healthcare sign language course. And they will be doing this course at the clinical stage of their program. And the next step after the students have acquired sign language is to administer questionnaires to them to see what happened with their knowledge and their interaction with their patients. So the questionnaires covered items, like it had 23 items, and they covered areas like relevance of sign language competence to clinical practice. Why is it that I have to learn this thing? I came to learn dentistry, I didn't come to the UE to learn another language. So that is what we would be covering in the questionnaire to see what they thought about it. We'll also look at why do I need to know about how the deaf community itself functions? Because many people don't understand that the deaf community forms a subculture and they have their own values and norms. For example, their politeness norms differ from the politeness norms of the hearing community. And this is important for healthcare workers to know so that they do not think that the deaf patient is being rude or improper just because their politeness norm differs. What are your expectations versus the reality of what you experience? So many students were apprehensive about their ability to communicate effectively with a deaf patient and to care for that patient at the same time. And the questionnaire asked how they expected that interaction to go and then how did it actually go. So it was very interesting for us to see the differences there. We also gave questionnaires to the deaf patients because the point of this is to serve them, and we wanted to know if they were benefiting from it. So we would ask on their questionnaire, which had 21 items, what was their communication preference? Would they want signed English? Would they want Jamaican Sign Language? Would they want note taking? Would they want an interpreter there, etc. And we also asked what their oral health practices were. Do you go to a dentist regularly? Is this the first time you've come to a dentist? Things like that. And if you've been to dentists before, were you able to communicate directly with that dentist using a sign language? And if yes or no, what were your experiences like? Was it pleasant? Did you feel as though you got the care that you expected? So these are the things that we wanted to find out from the patients. And we also needed to know what was your communication experience at UMDP as compared to other places where you may not have had communication access. So I'm going to hand over now to Dr. Alexis Garcia, and she will go through the results.
Okay, so we have data collected over a 5-year period, somewhere between 2015 2021, and we collected data from 40 participants, and that was 40 student dentists that were participating on the program. Of these, 33 indicated no previous interaction with a deaf patient, with the remainder completing the questionnaire after a previous clinical session. Most student dentists were young adults, so you could see their age between 21 and 30, and most were female. The students represented several CARICOM countries, including Barbados, the Cayman Islands, Trinidad and Tobago, Jamaica, and Guyana. So we started by looking at what happened in student dentists who had no prior experience of treating deaf patients. And we could see here that the results showed that they reported feelings of anxiety. So over 75% of the student dentists with no prior experience of treating deaf patients reported anxiety before treating their patients. This, however, was really short-lived and reduced to about 6% after treating the deaf patient, and was replaced with reports of happiness and excitement by approximately 80% of the student dentists. There was, however, a significant association between student dentists' anxiety ratings and the mistakes that they made, with more anxious student dentists reporting fewer mistakes, but when these were made, they reported having more negative feelings, such as feelings of frustration or feelings of anger. Though the student dentist anxiety levels were high, the experience of the deaf patients were very positive, with only 3% reporting negative feelings like frustration as a result of any mistakes made by the student dentists. Most students also reported understanding the patient signing and being understood by the patient, and approximately 70% selected direct signed communication with deaf patients as their preferred method of communication. So the introduction of sign language to the dental program was not done in isolation. So students also had to learn about deaf culture as part of their training. So this correlation matrix table shows the relationships between deaf culture, dental practice, and sign language competence. I just want to focus here on the relationships that are highlighted in red, and particular the one at the bottom, which is the relationship between working knowledge of deaf culture and dentists having sign language competence, which is circled in blue. So there were significant positive associations between the importance of learning about deaf culture before having a deaf patient and the relevance of that to deaf culture and to practice. These significant positive correlations show that the more the student dentists learned about deaf culture, the more they saw the relevance to practice and to having sign language competence. We also compared those with no prior experience of treating deaf patients with those who were exposed to early clinical experiences, and largely the results were as expected, as dental students with early clinical experience were less anxious about treating deaf patients, more likely to understand the patient's signing, and to think the patient understood them. In addition, these dental students reported making significantly less mistakes when signing, but were more likely to express negative feelings such as disappointment and frustration when these mistakes occurred. And you could see in the table here that those with no prior experience compared to those with prior experience of treating deaf patients, you could see the differences there so for example, in the first criteria where the dental student understood the patient signing most or all of the time, those with prior experience, over approximately 86% of them said that they understood that most or all of the time, compared to 60% of those with no prior experience. We then had a look at the student dentist attitudes, and we looked at that pre and post 2017. So I'm just going to explain why we had a separation between pre and post 2017. So the 2015 and 2016 students matriculated on schedule and completed their programs within 5 years. But from 2017, some students failed to matriculate and changed cohorts. In addition to that, an external accreditation exercise in 2016. So after the accreditation exercise in 2016, the program adopted the recommendation to expose all students to clinical activity earlier in the program. This meant that instead of treating students for the first time at the end of year 4, 26 students started treating deaf patients in year 3. This earlier start brought forward the transition from the didactic to the clinical component and led to students participating in the study a year earlier than previous cohorts did. So I just have a bar chart here that kind of demonstrates what's happened pre and post 2017 on student dentist perceptions of being understood by deaf patients and on their ratings on if they understood their deaf patient signing. And we could see here well, the graph shows significant differences existed pre and post 2017 on dental students' perceptions of being understood when signing. And I just want you to look here at the blue charts, because that's where our significant differences kind of became more apparent. Okay. In all cases, whether with or without prior clinical experience or pre or post 2017, the majority of the student dentists indicated a preference for direct sign language to the use of an interpreter or that of a parent. So finally, what do these findings mean? So first, that student dentists preferred method of communication was direct sign language as opposed to the use of an interpreter or parent. And this is supported from previous research. So previous research has suggested that sign language should form part of the dental curriculum, as it may help to improve this dentist-patient relationship. Other studies have shown that dental students with poor communication skills tend to have lower confidence in treating their patients during undergraduate training. And communication is essential in delivering services to patients. So the results of this study has shown that student dentists have valued being able to communicate directly with their deaf patients and have chosen direct sign language as their preferred method of communication. There was also less communication anxiety when clinical activity was introduced earlier into the program. So the change in the program in 2017 introduced clinical activity earlier in the curriculum, and this change helped to reduce levels of anxiety in student dentist interactions with deaf patients. This led to more confidence in their subsequent interactions with patients and developed a strong rapport with the patients who were then more inclined to access dental care at the UWI Mona Dental Polyclinic. However, student confidence in their signing skills decreased because of the earlier introduction to clinical competency. This may have occurred as the student dentists had less time to practice before seeing their deaf patients. This study also gave deaf patients a voice. So even though student dentists made mistakes when signing, these were overlooked by the deaf patients, and the patients reported being happy that the student dentist was communicating directly with them. And finally, that sign language should not be learnt in isolation. And that an understanding of deaf culture is important. So hearing persons tend to bring the pragmatics of English communication to their communication with deaf persons. And learning to sign without learning deaf culture places the signer in a vacuum where they cannot communicate appropriately. So I'm going to hand back over to Dr. Kumbach.
All right, so some of the challenges that we saw that we need to overcome as a part of perfecting this intervention was reducing the anxiety of the student dentists and increasing their confidence. And we also thought that we can extend and promote the use of sign language in the dental domain in all CARICOM countries. And how are we going to achieve these things? So these are the recommendations. With regards to the latter, what happens now is, for example, if we had a student graduate recently from Guyana, and I contacted the Deaf Association of Guyana, asking them to link with the student and to inform the deaf that they now have a signing dentist available to them at a public facility in Guyana. So they then contacted her and arranged for how she'll be able to treat deaf patients. And this is the type of relationship we want to see throughout CARICOM. We want the students to be able to serve the deaf patients when they graduate. outside of just the UWI Monodental Polyclinic. And we think that one way of formalizing this process would be to have the UWI PVC for Global Affairs, as the Pro-Vice Chancellor, linking with CARICOM and asking CARICOM to establish direct links with all their governmental and non-governmental organizations that serve and address deaf welfare, so that we will be able to know all of the organizations across CARICOM that we will need to contact to say, we have a student returning to your territory who can serve your deaf communities. The next,
Dr. Cumberbatch, just to indicate that your time is up, but I'll give you you know, a minute or two to finalize your presentation, please. Just another minute or two.
Thank you. This is the penultimate slide. So you would see a picture of an outreach activity here, and what we said we will do to help the students feel more comfortable is to have more outreach activities that include deaf patients, so that they have more opportunities to practice their signing outside of the clinic. And also, if you pay attention to where I put a circle there, in that corner you have students from UWISON, that is the UWI School of Nursing, who are also present, and we said more FMS students, more FMS programs should also include sign language in their clinical training, so that healthcare workers can truly work as a team in patient management for deaf patients. And we have had pharmacy follow dentistry in making sign language mandatory at the clinical stage for their students. So our conclusion is that we can say definitely we have evidence that healthcare workers using a natural sign language to communicate directly with deaf patients is what is best. We have seen treatment outcomes improve. We have seen oral health practices improve and normalize. And by that we mean that we see people coming for maintenance, just regular cleaning every 6 months, and they're not waiting until they have an abscess or something causing an emergency before they come to clinic. We have deaf children now understanding that going to the dentist is something that they have to do twice a year. And this was not the case. When we first started, we had most of our deaf in their 30s saying it was their first visit to a dentist. And we have deaf patients feeling seen and validated as patients because their language was accepted in healthcare as a communication method, and the language barrier causing that disability was removed, so they were treated equally to hearing patients, achieving the mandates of the CARICOM Declaration and of the UNCRPD. Thank you very much.
Thank you.
Thank you very much, Dr. Cumberbatch, and also Dr. Camille Alexis Garcia. I had not introduced Dr. Garcia at the outset, but just to let you know that she is an associate professor of health psychology in the School of Science and Technology at Middlesex University, London. Dr. Alexis Garcia is also a chartered psychologist, with her main research interest being the evaluation of theory-based behavioral change interventions with relevance to public health. And I also want to recognize Dr. Theon Jones, who is the head of the UWI Mona School of Dentistry. His research interests are special needs and dentistry and social accountability in dentistry. And I really want to congratulate him for leading the way in ensuring that the UWI dental program had as a requirement for all graduates to be competent in signing. And not only that, that is now leading the way for the pharmacy students to also be required to sign. And as an agency of the Ministry of Health with responsibility for healthcare delivery for pharmacies, we know how important that is. And here at NHF, we are also seeking to get our pharmacists and our customer service representatives competent in sign language. So this is very important, as we have heard throughout yesterday and today. Increasing the access to healthcare is so critical for persons with disabilities. So thank you very much for the work that you have done and the way that you have led for health professionals in this regard. And it's also significant that you noted that it's not only having the competence, but also learning about deaf culture. Really eye-opening, wonderful presentation. Thank you so much. Are we going to take any questions at this time? If there are any questions, you may type in the chat. I'm not seeing any questions at all. Okay, so if not, then I will just wrap up at this time. And again, on behalf of Mr. Everett Anderson, the Chief Executive Officer here at the National Health Fund, it has been our pleasure to participate in this conference and also to have been a sponsor of this very, very important conference for Jamaica and for the entire Caribbean, and for opening up our eyes and our thoughts to how we in the health sector can ensure that we provide access to persons with disability. Thanks again to the UWI Dental Program team for their presentation. And I now hand back to the chair of the conference. Thank you.
Chair, I'd just like to point out, Louise Swinton had raised her hand, and I wanted to address something that she had asked earlier this morning, and they told her to wait until this afternoon. She was speaking about her daughter, and I was thinking of, I don't know if she's aware of Dr. Blair at Signature Dental, who does see special needs patients, and she also uses anesthesia. And I know the cost, for example, for the general anesthesia is no more than 60,000 or so. So I think that she could explore Signature Dental as an option. And I don't know if I see her hand is raised, so I don't know if that.
Right. I'm afraid, I'm so sorry. I did not see her hand at all. So can we allow her to ask her question? So, we'll know exactly what it is, Dr. Cumberbatch, you were responding to.
Okay, I'm so happy that you respond to me. Thanks. Their information is very informative, but I need to know more about how can I go about to get dental maintenance, not to just go and extract a tooth, but to maintain that she can keep her teeth in good health condition. But as you say, as you mentioned, thank you very much, that she has to do anesthetic because of the movement in her body. She doesn't settle on her own that readily. So I do not know anywhere in Jamaica where I can get that service without privately. So that's where I'm seeking help from you now. How can I go about it if there's one for me to go about?
All right, so as I said, Signature Dental is an option, and Dr. Jones, if he can respond, he can let you know that the school is working towards, we do treat special needs patients, but we don't have anesthesia available for them now, and the school is working towards that. I don't know if he wants to add anything on that.
Well, the good thing about it, she has done one recently, so she would need to go to one exactly now, but it's like every 2 years or so I have to go in for that treatment. But if maybe your setting would have wanted her to come in a little quicker, but because of the cost, I normally doesn't go in until after every 2 years.
Okay, but you can explore Signature Dental. It should cost you much less.
Where?
Could you repeat the name of the office?
Signature Dental, it's on Old Hope Road at El Shaddai Medical.
Oh, El Shaddai Medical?
Yes.
Okay. So what part of it of Hope Road?
It's near the Texaco and obliquely opposite.
No, you said something before El Shaddai Medical. I don't know. I don't do her.
Signature Dental. Signature Dental.
What kind of dental?
Signature. That's the name
Signature.
of Signature is the
Okay.
name of it. They're
Signature
located.
dental.
Yeah, they're located there. I had sent it to you in the chat.
Right.
Yes.
Oh yes.
Thanks.
Thank you, Miss Roberta. Thank you so much. Just put it in the chat.
Thank you very much for remembering my call this morning. We appreciate it. And you have a good day. And thanks very much for this conference. I really appreciate it a lot. And I learned a lot from you also. Okay. Thanks very much.
Thank you. And I see another hand is up. Nikela Cumberbatch, your hand is up. Please go ahead with your question.
Yes, hi. It's an observation. I am a multiple sclerosis patient. I recently would have lost my job due to my symptoms. So I have two observations. One would be for a condition or person who would be recently disabled, but has a prospect of regaining some function. There is no way throughout the structure of the public servant sector to be able to come off from work for 2 years, let's say, or over 1 year, and still be able to pick back up your job or some kind of employment. Because from the minute you start any kind of employment, the welfare system breaks down for you. That's one. So it means that if you stop, they are saying, well, you have to stay pause because there is no starting back in whatever capacity. I remember when I was a child and I heard that being disabled is differently able. Now that I am entering into disability, I'm recognizing that that is really just a catchphrase, but it means that you have to more or less become an elderly person if you are an adult and develop disability. That's one. And then two, the dentist is a very interesting part for me because I remember saying to myself, I'd love to go to the dentist, but one, I can't afford it. And even if I could afford it, I don't want the judgment of someone saying, well, you need to eat better or you need to brush your teeth twice a day. And I'm saying to myself in my head, well, I'd love to eat better, but I can't afford it. I'd love to brush my teeth twice, but I am too tired to be able to do this, and I have to make certain things a choice. So if a person is going to help, I think that we like it with less judgment. And not to mention, if a person is born disabled, there is more open to them than a person who develops a disability. There's a lot more, but this is not the time. We are out of time, but those two things are very pertinent. So thank you very much. I've learned a lot. It was a very long conference and it was very trying and testing, but it was definitely worth it. So thank you, everybody.
Ms. Cumberbatch, we couldn't agree with you more in relation to the significance and the importance and the amount of learning that took place over the last 2 days in this conference. And we have noted your observations, and we certainly hope that we in the health sector can do our best to address some of the issues that you have raised. There being no other comments or questions, I see no other hands or other comments in the chat. It is now time to hand back to the chair of the conference. All the best to you.
Yes, thank you very much for this session. Thanks to the presenters and to the moderator and to NHF. And we have had 2 full days of interrogating issues related to health issues related to persons with disabilities. I'm sure listening to the wide variety of presentations and the various issues. It has opened our mind. The conference has opened our mind to not capturing health issues under a small umbrella, but it is much wider than where we are right now. But we have examined the issues that we can relate to, and we have examined issues that we did not know about and are learning. And we trust that all our audience, members of our audience, all our presenters, all our moderators, and our audience here and online really benefited from this conference. And we want to extend a big thank you to the hardworking team. I know Senator Morris will say it as well, but as the moderator, to the hardworking team behind the scenes, you are hearing me and seeing me and hearing maybe Senator Morris and a few other persons, but we had our hardworking team, and we want to thank you all. And we're happy that at least we were able to engage at least a member of a segment of the audience until the end. And thank you very much. And I'm now going to hand over to Senator Morris for the closing remarks. It was my pleasure chairing the 2 days program.
Thank you. Thank you very much, Miss Gloria Goff, for your tremendous work and effort over the past 2 days. And as the chair for the conference, I am tasked with giving the closing remarks. And in doing so, there are 2 things that I'm going to be doing. One is to thank the audience for their participation and the members who contributed. But also I want to just announce the findings. Okay, I want to announce the findings of the 2021 Regional Disability Index, based on the survey that we had conducted, and those results can be seen on the center's website in detail, but I'm just going to announce the ranking in order. In first place, based on the ranking, is the Bahamas, then Barbados. Jamaica is in third, Grenada is in fourth, St. Lucia is in fifth, Antigua and Barbuda in sixth, Trinidad and Tobago in seventh, Guyana in eighth, St. Kitts and Nevis in ninth. Those are the countries that participated in the index for 2021, and you can see the details on how the ranking was conducted on the UWI CDS website, and the next ranking will be published in 2023. Now, I am really grateful to the individuals who contributed to the conference over the past 2 days. Extremely grateful to the presenters who did extensive work on their papers and made tremendous presentation during the 2 days, and we are deeply grateful for those presentations, and we are looking forward to compiling those presentations, the best ones from the conference, because we are going to have them peer reviewed, and when we have documents that are peer reviewed, you have to make sure that they meet a particular standard based on what the publisher would want and in keeping with best practices. And so we're going to be compiling those and sending them to the publisher for review, and then we will take it from there. Also want to thank the audience for, really their participation, because they constitute a part of the review process as well, in terms of their input, their recommendations, their contributions, and we thank them for staying with us until this moment. I want to thank the sponsors, because without the sponsors, the event would not have been successful. And they are deeply grateful to the National Health Fund, the Digicel Foundation, the University of the West Indies, for the tremendous support that has been given over the past 2 days. And most importantly, I want to thank the members of the committee for the support that they have given to me in guiding and executing the conference over the past 6 or so months. And, the work that has been done has been tremendous. And I deeply appreciate the effort. Yesterday, I named all the members of the committee, and I will not go back through all the names of those individuals today, but just to say that I am really grateful and heartened by your contribution and your input and your support, because no one individual can execute and implement a conference. It has to be a team effort. And even though I'm leading the team, it is the team that has to be commended as well for the tremendous support and effort. And I want to thank the technical support from the regional headquarters and from the Faculty of Social Sciences for sticking with us and making sure that the conference enjoyed the success that this has had to date. We're really grateful for all individuals, and most definitely, so thank you very much, Madam Coordinator, for reminding me of the interpreter who gave such tremendous support for the conference. And the deaf community is very important in the whole disability agenda, and so having the interpreters were very instrumental in ensuring that the needs of that community were catered to. And we want to express our profound appreciation. And we look forward to Conference 2024 as we continue to push the disability agenda for persons with disabilities in the Anglophone Caribbean. Thank you very much. And I'm going to ask the members of the committee for 5 minutes of their time as we do a final committee evaluation, and then we part. Thank you very much. God be with you, and we wish you all the best for the rest of the afternoon and the rest of the year. Thank you very much.
It's a last week. No, you aren't. Just looking at me, right?
Turn off the mic, please.
The mic's not turning.